Brahma, Gurur Vishnu, Gurur Devo Maheshwaraha, Gurut Sakshat Parabrahma Tasmai Sri Gurave Namaha. With the blessings of all the gurus, rishis, teachers, masters, and all the stalwarts who made it possible for us to experience the healing powers of Ayurveda, today we are celebrating the 100th years of establishment of Sitaram Ayurveda Private Limited. And as a part of our celebration, today is the second day of the technical session on Prameha Samagra Avalokanam. And in today, we are blessed to have some really insightful dignitaries as a part of the event. And the session is chaired by Dr. Muraleedharan sir, trustee of Kottakkal Ayurvedashala Trust. And we have the moderator, Dr. S.P. Sreejit, who is a doctor from the Indian System of Medicine. And we are having the speakers, Dr. Sreeja Sukesan, Dr. Jomon Joseph Daniel, Dr. Gopi Krishna, and Dr. Vishal Govindhari. And in today's event, we will be discussing about the associated illness with diabetes, as today is also the Diabetes Day, and we understand how much metabolic disorders are creating a lot of problems. And the concept of Santarpana Vyadhi was mentioned centuries ago in Ayurveda, which is becoming more and more relevant today than any other time. And we understand the powers of holistic healing, that every part of the body, we cannot just isolate it, it's a whole part. Every event is interrelated with every other part of the body. So now we today start the session, and I invite Dr. Sreejit, who will be the moderator today. Thank you.
Namaste to all of you. We'll make this day very eventful, not only for today, but also for coming days. Sreejit is my name. I happen to be the moderator of this session. Before we go further, with loads and loads of clinical experiences, let us take few time to create a sense of reverence and homage to all those who made this possible. Chaturmukha Samarambham, Sushruta Acharya Madhyamam, Charaka Acharya Madhyamam, Vagbhada Acharya Madhyamam, Asmad Acharya Paryantam, Vandeham, Guru Paramparam, Vandeham, Vaidya Paramparam. We are never complete unless we have the blessings of the generations before us, because this would be an essential blessing for us to forge ahead in our system. The sessions today would be very much brainstorming, and I would like to comment very clearly to you that it will be very sharp and very compact, and we promise you on behalf of Sitaram management, I got the permission and the endorsement that if you feel that some sessions were too short for the merit of the faculties, it is because of the time constraint we have, and we promise you that you will definitely have the blessings and the presence of those faculties in the form of next class. So these sessions, the most important person is none other than Dr. K. Muraleedharan sir. He needs no introduction. And I'm not here to speak about his official qualifications. Every one of us know how great he is. All of us know that. But there are some ethos we can learn from him. And whatever I speak to you would not be so-called official information that you may find in the internet about him. It's very specific, clearly intelligence report about what kind of a great personality he is. And that's from very reliable sources, my friends who are his juniors. Dr. K. Muraleedhar Sharma sir is not just a physician of the highest order. He's a great human being also. His personal humility, his down-to-earth attitude, and most importantly, his compassion towards patients is just unparalleled and at a very bigger level than we may really find in common practice. He had the blessing to be a very close, and I say this with utmost respect to his individual professional merit. There's no discounting that at all. Apart from his own great merit professionally, he had the blessing of being in very close contact, professional close contact and personal close contact with the great Bhishmacharyas of our era. Dr. P.K. Warrior sir, Dr. K. Rajagopalan sir. They need no introduction to anyone. So for many decades, he was with them. So that always added to a lot of richness in his experience. And I'm told that the amount of energy and enthusiasm and clarity Dr. Muraleedharan Sharma sir is having is that he has so much of enthusiasm, even from the last to the first patient and the first to the last throughout. He's such a crowd puller practitioner of AVS that, in spite of his extremely busy and taxing schedules, he maintains that kind of freshness as if the last patient he sees, however late it is at night, whenever, is as if the first person. That is the level of energy he carries. I thought it is important that we convey to this to the entire community of doctors who are watching this. So I think these are the ethos that we have to know about him. The last two things, his penchant in handling rare diseases is unparalleled. His amazing level of success in rare diseases, that's what I have been conveyed. Not by him, but by people who know him very well in close quarters. And last but not the least, his writing skills is just amazing. His writings are in such medical, authoritative, authentic manner that it really hammers your brain with precise clinical input. At the same time, his writings literally pierce your heart at an emotional content, at an emotional quote. So I think that's what we can carry back from him. This is the least I can say about him. And these are not things you will find in the internet. That the ability to be professionally very fantastic and also personally very sober and humble. These are the ethos youngsters like us should imbibe from him. And sir, I hand over the situation to you. We request your thoughts on today's topic. And once sir has conveyed his thoughts, I will take over the moderation part where we would invite Dr. Sreeja Sukesan madam about the retinopathy aspects of diabetic, and then I think we are in full flow today. I again say to all of you, once again with humble request, kindly don't be disappointed if you feel the sessions are cut short. Nothing like that. We will definitely have the blessings of these great clinicians again, and so we are full on now. Sir, all over to you now.
Good morning, respected fellow participants and friends. First of all, let me express my heartfelt gratitude to Dr. Ramanathan sir and other members of Sitaram family for giving me a wonderful opportunity to be a part of this scientific seminar. Ayurvedishala congratulates Dr. Ramanathan sir, his predecessors and his colleagues for having achieved 100 years of meaningful existence as an excellent Ayurvedic institution. With these few words of introduction, let me pass on to the responsibility entrusted upon me. I am expected to talk a few words as opening remarks in this session. I would like to go by the time schedule as far as possible, so I opt to read out the speech instead of making an extempore one. Let me start humbly, placing a few questions related to diabetes. How old diabetes mellitus is? As far as our knowledge goes, it is at any rate more than 3,000 years. Now let me place before you a second question. Despite the explosion of medical knowledge and technical advances, why diabetes mellitus continues to be a threat to human life? It may be rather difficult to answer this question easily. The evasiveness to answer this question is well understood. It may be rather difficult to answer this question easily. The evasiveness indicates that we are running off the track, at least in some areas of diabetic management. It may be remembered here that diabetes increased significantly in both sexes, every age group, every racial and ethnic groups, regardless of socioeconomic and cultural levels. How did this ancient disease suddenly become the 21st century plague? Our health authorities failed to offer a convincing explanation for this. Categorically, it is explained that diabetes mellitus is a chronic progressive disease that leads to life of painful decline and early death. There is nothing new in it. Ayurvedic physicians centuries ago classified Prameha as Mahavyadhi which contains almost all the new interpretations. However, there has been a deeper and more comprehensive understanding about diabetes mellitus. For example, in 1959, the two different types of diabetes mellitus were formally recognized. Type 1 or insulin-dependent diabetes mellitus and type 2 non-insulin dependent diabetes mellitus. These terms were not entirely accurate as many type 2 diabetes patients were also prescribed insulin. So by 2003, the terms IDDM and NIDDM were abandoned, rather modified as type 1 and type 2. Another important understanding about type 1 diabetes mellitus is that it's an autoimmune disease. It means that the body's own immune system damages cells that secrete insulin. Cumulative destruction of insulin-producing cells causes type 1 diabetes mellitus. As a reflection to this observation, we may recall the insight of ancient Ayurvedic physicians in recommending Guluji, Pinospora cordifolia, as the first line of treatment for diabetes mellitus. The therapeutic potentials of Guluji as an immune modulator is well-established fact. Viewed from this perspective, Guluji has much relevance in the management of type 1 diabetes mellitus, add-on medicament. Why add-on medicament? The answer is simple. One cannot now logically think of replacing insulin administration in type 1 diabetes patients because insulin has dramatically improved the prognosis of diabetes mellitus. One thing to be noted here is that insulin helped better management of blood glucose levels, but disease per se remains more or less unchanged, leading to predestined complications. Otherwise, it would have been possible to prevent complications as one may wish. Type 2 diabetes mellitus was believed to be a disease of other older adults, but the prevalence is progressively rising in young adults, especially in obese individuals. Hyperglycemia in diabetes mellitus 2 is primarily due to insulin resistance rather than insufficiency of insulin. To put it in simple terms, the failure of the system to lower blood sugar utilizing the plenty available insulin is called insulin resistance. Body tries to overcome this resistance by producing more and more insulin and fails after a certain stage, leading to rise in sugar levels and accumulation of underutilized insulin. It is very clear from the above facts that the treatment protocol of diabetes 1 and diabetes 2 are to be different. What happens when excessive glucose piles up in the body over 10 or 20 years? Every cell in the body starts decaying. Decay, degeneration, and death of cells happen gradually. Diabetes mellitus has malignant potential to devastate the entire body. Practically no organ system remains unaffected. The complications are classified into two. I know my fellow participants are going to go into the details of it. Microvascular and macrovascular. Microvascular changes affect the eyes, kidneys, and nerves. Diseases of the heart, brain, lower limbs belong to the other group. There is no reason to believe that standard medication prevents the progression of organ failure because they do not eliminate the toxic sugar load. We may remember here that Ayurveda primarily recommends appropriate Snehana and Shvedana therapy as a first step of treatment. Here, specifically, Sarshapatailam, Nimbadailam, Dandidailam, etc. are recommended for Snehana. And similarly, for Shodhana, Surasadhigana, Negrodhadhigana, etc. We may note the differences in the approach of two systems. Guided by our experience, it is felt that Ayurvedic prescription of diabetes mellitus also requires a relook because medicines like Dhanvantara Gradam are seldom seen in new prescriptions. It could be due to the apprehension about the use of ghee-based preparation. In fact, there is no taboo in using ghee-based preparations in appropriate dosage in diabetic patients. According to Ayurveda, ghee is the most adaptogenic to the body and has rich dasayana potentials. The role of ghee in preservation of brain health is well known, and is recommended to be used at appropriate stages of various diseases. Ghee-based preparations therefore should find a place in Ayurvedic prescriptions of diabetes mellitus. It would prevent brain degenerative diseases like dementia, Alzheimer's, etc. Incidentally, I would like to make a reference to Alzheimer's disease, which is steadily on increase. It is observed that there is a link between Alzheimer's disease and diabetes mellitus. Researchers have observed that there is a selective insulin resistance in the brain of Alzheimer's disease patients. According to some researchers, Alzheimer's disease can be even called type 3 diabetes mellitus. That is a very important information, it seems. Similarly, diabetic oncopathy is another emerging complication of diabetes mellitus. Patients with diabetes mellitus and cancer are encountered in clinical practice. In our cancer care unit, on an informal study, we could find out that roughly 18% of cancer patients have concurrent diabetes mellitus. It makes the treatment rather complicated. Epidemiological data suggests patients with diabetes mellitus have high risk of developing cancer. It includes liver, pancreas, colorectal, gynecological, and breast. Naturally, the underlying cause could be the glucose metabolism abnormalities. I would like to conclude this speech here. I'm sure the experts who are going to make presentation in this session would enlighten deeply on various aspects of clinical management of diabetes and its complications. Once again, I thank you for patient hearing and thank Dr. Ramanathan sir for giving me an opportunity to interact with the experts of this field. Thank you very much.
Sir, thank you very much. Definitely type 3 diabetes is a totally new term for many of us, but as we will explore more and more, now I must invite my mentor of many of us in the government service, Dr. Sreeja Sukesan ma'am, MD, PhD. Again, everyone knows her, but think it's more important for me to bring down to your notice the ethos that she believes in, the ethos she lives her professional life. Number first is that extremely hard worker, even in the comfort zone of being a government servant, government professor. She took the daring and audacious step of nearly challenging her own social and personal life by going to BHU for PhD without any benefits from the government. And that is something very few people would dare to do. It takes a lot of heart and courage to do that. That's one thing we can learn from her. Extremely hard worker. Secondly, meticulous documenter. She documents to the utmost clarity of any possible level, in all possible forms. And she maintains a very good feedback. And her feedbacks are as long as 20, 22 years. Thirdly is a passion. And very assertive about Ayush, very assertive about Ayurveda. The passion to teach students with utmost clarity and also with sincerity. I have seen her this, and I don't say from any other person's second-hand information. I have been blessed to be in her private OPD, in her home OPD on weekly basis for 1.5 years, and have seen that firsthand. The amount of results she would bring in retinopathy and many other situations with eye is so Herculean big. She would lament to me personally, Sreejit. I use the word lament. Sreejit, I have so much in my hand, but how do I make it reach to pan-India level? As a teacher, we'll do our best to get it all over. And we are happy. Dr. Vignesh Devraj and Dr. Ramanathan sir have shown the interest to bring this knowledge to wider section of the Ayurvedic fraternity. So this kind of clarity with which she communicates is unparalleled. Fourthly, is her commitment not just as a clinician, but also as a researcher, as a documenter, as a keen observer who wishes to bring this to the public's domain. And she again, I would say, I use the word lament, would lament the fact how Elanir Koram is misused and overused even in conditions which are not actually suitable for it. And how she would say, you'll see that further, the role of that in diabetic, this situation of retinopathy. The last thing about her, if not the least, I can't use more than 3 minutes to narrate about any faculty, is that her enthusiasm for a crusade. I would use the word crusade, an Ayurvedic crusade for the public's welfare. Her openness to join hands with other systems of medicines, including allopathy, of course, for a better society where blindness can be prevented as far as it can be. Last thing I would say about her, and that's again my first-hand information, is that she has avoided suicides of people. And not many people know that. Myself and the next faculty, Dr. Jomon, Joseph Daniel, we are her boys, we are her students. And so we take a lot of pride in knowing her and being her students. So we have been told by her is that there were situations where people, they said, I'm dying, no more. And then they happened to see the webinar where she had commented about cure of retinopathy, and people had approached her, and such things have even happened. So that's why she says that the knowledge that she has of more than 1,000 plus patients of this specific condition should go as a mass scale copy pastable manner, in a mass scale, so that it spreads pan India. And this is a very, very special feature of her personality that is a blessing for all of us. Ma'am, you are most welcome. We call her teacher, we don't call her ma'am. Teacher, you're most welcome. And teacher, as you know, we have time constraints, but we all know that you would bless us again with your clinical information. And this I would be commenting in every speaker's narration, that we would definitely have the blessings of these great stalwarts for us. Ma'am, we are all yours now. Kindly enrich our brain, and I'm sure that we will be definitely profited by your vast and very special experiences, which are well documented and well followed up. I hand over to Sreeja ma'am to enlighten all of us.
Thank you, Sreejit. Thank you. Most respected Muraleedharan sir, the chair of this session, and my beloved student and moderator of the session, Dr. Sreejit, and most respected Ramanathan sir, Dr. Vishal, my fellow presenter, and Dr. Vignesh, and all other members of Sitaram family. My humble pranam to one and all of you for giving me such a wonderful space in this auspicious occasion of centenary celebration of Sitaram Private Pharmaceutical. So let's start. So today's presentation is all about the management of Ayurvedic management of diabetic retinopathy. And I'm having a very limited time, as you know. So as a part of introduction, I wish to share you what is the scope of Ayurveda in the management of diabetic retinopathy. If you ask this question to 10 Shalakya specialists, I'm sure you may get 10 different answers, 10 different answers. The main reason is we don't have a standard guideline for the management of diabetic retinopathy, not only for diabetic retinopathy, any of the diseases belong to Ayurvedic classes. And the next thing is we don't have an apex body. We don't have an apex body to guide us. So we are having the freedom. We are really very flexible to whatever we know we can implement, we can do, and we are much relaxed. So how we can assess the scope of Ayurveda in the management of diabetic retinopathy? It is really tough. And I do feel there are various things or various criteria that determine the scope of Ayurveda in the management of diabetic retinopathy. The first and foremost important thing is your knowledge, your knowledge. How much effort you took to understand the disease in terms of dosha, and the skill to understand the modern interpretations, modern investigative techniques. And the other thing is your patience, to follow the patient. You have to follow for years to speak authentically about the scope of Ayurveda. And finally, you have to compare what I can provide to the society who are affected with diabetic retinopathy. Is it equal, or is it somewhat less, or is it much more than what can provide by the accepted protocol or the accepted standard protocol that is available? So these are the ways how we can understand the scope. And when we move forward, I'm sure you will be convinced how I assess the scope, how I understand or how I share the scope of Ayurveda in management of diabetic retinopathy. Even though we can provide internationally challenging result to the patients suffering from diabetic retinopathy, I'm really very sorry because we are not a part of National Blindness Control Program. Ayurveda is not yet considered as a part of blindness control program. I don't know why. And the main thing maybe we don't have a standard guideline. Each of us have separate plan or typical packages to manage. So we don't have a unique or a common outcome. Our outcome is different for each single persons who are handling the disease. And that may be the main reason we are not at all accepted till date in the management of or controlling blindness program, at least in Kerala. And the other thing is the public is not at all aware about what we can provide to them. And this is the main reason most of the patients approach us in the very delayed stage of diabetic retinopathy. Sometimes one eye may be totally blind and the other eye may be 50% blind. This is the state when a patient chooses Ayurveda for the management of their problem. And I do feel we should develop a standard guideline in this area because this is the most leading cause of blindness, especially diabetes mellitus is concerned. Kerala is the top most line in the prevalence of diabetes and so the complications of the diabetes. So we need vigorous training in this area. The whole physicians, including the specialists, need vigorous training so that we can make very good standard guideline and finally that can be implemented. So in this presentation, I wish to share you how to understand Ayurveda in terms of modern investigative techniques so that you can make a very good plan for the management of diabetic retinopathy. And again, there are cases to show you Ayurveda versus modern invasive techniques like laser and IVI, intravitreal injections or invasive techniques. And again, I will explore some local treatments. Tarpana is really dangerous in the management of diabetic retinopathy with some clinical experience. And the last title I wish to share is a thorough Ayurvedic knowledge that is the minimum need to treat any disease and so diabetic retinopathy. As you know, diabetic retinopathy is the 5th leading cause of blindness. And every single day, the prevalence of diabetes is increasing, and so the diabetic retinopathy is also increasing. And it will be doubled by 2030. And it is making blind the working population of India. That is really very serious. So I don't wish to elaborate the diabetes prevalence incidence and all. I wish to limit all these things and I wish directly come to the topic of diabetic retinopathy. So before discussing the diabetic retinopathy, I wish to share you a little bit about the Drishti and Ayurvedic concepts of diabetic retinopathy. Drishti is the part or it involves almost all the vital structures of the eye which enhance normal visual function. So it starts from the cornea, the lens, the vitreous, the retina and the optic nerve. And we are having a separate disease that is Drishtigata Roga, which explore 18 different categories of Timira, Kaja, and Linganasha. There are 18 different categories, that is Timira, Vada, Pitta, Kapha, Rekta, Samsargaja, and Sanibadaja. Likewise, Kaja and Linganasha, together it makes 18 types. So these 18 types of Timira, Kaja, and Linganasha, this is sufficient enough to treat any kind of visual failure that is available in our clinics. So Timira is the initial stage of visual failure and Linganasha is the end stage where the vision is totally lost and Kaja is the intermediate stage. So timiram kajadam yadi kajam apyantyam upekshaya netra rogeshu adokhoram timiram sadayet dhruvam. This is the quotation that we made in Ashtanga Hridaya. So this is really very important. This sloga, this part of sloga is very important because Timira, if you address the Timira in a very right way in the beginning, you can avoid blindness. Otherwise, it may lead to any misappropriate management or any delay in diagnosing and treating the Timira may lead to total blindness. So it is advised that we have to treat or we have to give the right treatment in the very beginning of the disease. And this is really tough. This is really tough for an Ayurvedic physician because Timira, it may be due to Vada, Pitta, Kapha, Rekta, Samsargaja or Sanipadaja. So whatever it is, in spite of the dosha which is involved in the pathogenesis, the patient complains of visual failure. There may not be any other significant associated complaints or signs that you can assess the dosha there. So whatever is the involved dosha, in spite of the dosha, the patient complained of visual failure or diminished vision. So from the diminished vision, you have to assess the dosha which is involved in the samrapti. It is really very tough for a Shalakya person who is not much skilled in understanding the drishti in terms of modern diagnostic techniques. This is the toughest area. So how to overcome all these limitations in our practice? And in my opinion, incorporating modern techniques, this is the only way that you can understand drishti or you can make the idea of involvement of dosha in a very transparent way. So it will help you to appreciate minimal pathological changes. If the pathological change is very minimal and if the patient is not having any complaint of diminished vision, the modern techniques help you to understand very minimal pathological changes. And surely it gives you the understanding of dosha in a very realistic way so that you can make a very good treatment plan. And finally, it's a sharp weapon to obtain the faith of the scientific society. So to me, all diagnostic techniques that makes the evaluation of the doshas in a very transparent way so that it is very easy to convey the message to the scientific society and we can implement the accurate treatment plan in the very onset of the disease. And again, structural and functional examinations are very important. So for structural examination, the very simple device that is ophthalmoscopy, that is direct and indirect. I hope every physician who handle diabetes can use this instrument so that you can screen or you can understand the early diabetic retinopathy changes. It is very easy to. And FFA, this is another technique. You can understand the deepest pathology that happens in the eye. And again, OCT, optical coherence tomography. This is a very important thing when we treat a patient with diabetic retinopathy because we can evaluate the changes that happens in between the treatment. Also, we can make a right plan. If you see edema or hard exudates, whatever it is, it will be very transparent. You can see the 10 layers of the retina so that we can assess it in a very right way. You can see the CMO. And USD is the another technique that when you can't see the retina, with the help of ophthalmoscope, in case of very severe bleeding, you can seek the help of USD so that you may get the right idea that what happens inside the eye. So these are the different modern techniques that I used in my clinical practice so that I can understand the doshas or I can understand the retina in terms of dosha and we can deliver the right treatment plan in the very early beginning of the disease. Likewise, what happens in Prameha, that is the samrapti of diabetes mellitus, it is explored in the chapter. Vastimasritya kurude prameha duchitaha kapha dushayitva vabukle dasedo resamisham pittam rektam avikshine kaphado. This is the quotation that we get in Ashtanga Hridaya. It explained the samrapti of Prameha. And I do feel the samrapti of diabetic retinopathy, it is not different from this samrapti of Prameha. The diabetic retinopathy that happens in the eye, initially, just like Prameha, there is predominance of Kapha. And gradually, the dosha pitta may gradually associate, and there may be severe bleeding. And finally, Vada is the predominant dosha. So Samrapti of diabetes is exactly the same that is happening in diabetic retinopathy. I will explain it later when we move further now slides. So as you know, in diabetes, the most dangerous complication is diabetic retinopathy, and there are diabetic retinopathy is nothing else. This is microangiopathy, lots of changes that are happening in capillaries. And the important one, that is the proliferation of the endothelial cells, thickening of the basement membrane, and thickening of this platelet, then viscosity of the plasma that is increased. All these indicate the involvement of Kapha. That is why I told you, just like Prameha, the Samrapti is initiated in the eye, especially by the Kapha, because it is a Sandarpanotha Vyadi. And this Kapha block the minute capillaries, where comes the role of Vada. Okay, and again, when hypooxygenation occurs at the other end of the capillaries, there generate new vessels, because there will be secretion of vascular endothelial growth factor in association with hypooxygenation of the retina. So because of that, new vessels may proliferate everywhere over the retina, and gradually these fragile new vessels may break, creating hemorrhage in the retina. Okay, so initiated by the dosha Kapha and ending in Vada, this is the Samrapti, what we get in Samrapti of diabetes, and we are getting the same Samrapti in the retina. And finally, after this very severe hemorrhage and in advanced diabetic retinopathy disease, you can see the fibrous element and gradually traction retinal detachment. This is what is happening in diabetic retinopathy. In terms of Ayurveda, we can see Kapha is the initial dosha, and it stay there till the end of the disease. It never relieve from the eye. And when we consider the Samrapti of PDR, the Rekta and Rektavahasrodha Dushti is much more. When we talk about the PDR, proliferative diabetic retinopathy, the Rektavahasrodha Dushti is much more, and neovascularization is much more. So when we treat PDR, we have to keep in mind that Rekta is the main dosha, but always there is Sannipada Jasrodho Dishti, but the Vikalpa Samrapti may vary. Okay, so there are different types of diabetic retinopathy, that is non-proliferative diabetic retinopathy, proliferative diabetic retinopathy, and advanced clinically when we speak about diabetic retinopathy. And I hope Dr. Vishal, he will explain all modern aspects, and let me come directly into the management of diabetic retinopathy, because the permitted time is very minimal to me. So the Ayurvedic management versus modern invasive technique, this is my first topic to be discussed. You can see, these are the patients with proliferative diabetic retinopathy. You can see Mr. Abraham, that is 2009. Now he's no more. He considered me in 2009 with very profuse vitreous hemorrhage, and I asked him for a FFA. He didn't go anywhere else. He don't even have a laser or a vitrectomy, nothing else. He's a man who is only treated through Ayurveda, genuine Ayurveda, and he died in 2020 with a very good vision, 6/5 vision. Now he is no more, and the next patient is Sinoj. There is a big list of patients who are having proliferative diabetic retinopathy and maintaining a very normal vision till now. And I will explain the case of Sinoj. He is 41 and he's having the diabetes for about 16 years with very poor diabetic control. He had a history of pan-retinal photocoagulation in 2013. This is supposed to be the golden standard of treatment. The laser management is supposed to be the golden standard in modern science till the advent of intravitreal injections. Now it is somewhat changed to intravitreal injection, Avastin injection, but even then the PRP or laser treatment is continued. And again, he did laser photocoagulation both years, From 2010 to 2015, he continued modern management. And 2016, he approached Government Ayurveda College, Tripunithura, when he was advised for intravitreal injections of Avastin. And he was admitted in Ayurveda College, Tripunithura twice. And you can see the fundus photograph. So here you can see the hemorrhagic spots and new vessels. So that how to differentiate proliferative diabetic retinopathy is, once if a patient is having a very profuse hemorrhage or neovascularization in any quadrant of the retina, you can make the diagnosis proliferative diabetic retinopathy. Here you can see intraretinal and pre-retinal hemorrhages, and here are the laser ablation patches. Even then, the recta and pitta, it is not relieved from the eye. Even after repeated sitting of pan-retinal photocoagulation, the recta and pitta, it is not at all relieved from the eye. It is creating bleeding again and again in the eye. This is what is seen in this fundus photograph. This is the right eye of the patient. And again, you can see after 1 month, you can see the hemorrhage is little bit reduced. And after 3 months, again, it is somewhat good. And you can see what happens in 6 months. In 6 months, almost all bleeding that is resolved. After 1 year, you just see the picture. So whenever I talk about PDR, I told you the new vessels, the growth of new vessel, it is much more in almost all part of the retina. And these vessels are fragile, and bleeding is the main feature of proliferative diabetic retinopathy. So in our science, there are chaturvidha upayas to arrest the bleeding: sandhana, skandana, pajana, and dadana. Vranaha kashayaha sandate, rectum skandayet himam. So we are having 2 different options rather than pajana and dahana. Even laser photocoagulation is an alternate option or modified technique of daha dharma. But before going to laser, for an Ayurvedic physician, there are other options to treat proliferative diabetic retinopathy. And you can see how the vessels relieved or regressed from the scene by the treatment of Ayurveda. Now you can see the fibrous element. This happens after a very single hemorrhage in the eye. This is fibrous element, and finally, in the later stage, all these fibrous element may give some sort of retraction retinal detachment. So even after the complete regression of the vessels, the treatments to be continued, so as to avoid all these complications that's happening further in the progress of the disease. The patient is not free from Ayurvedic management. So at this time, we have to change all our treatment. We cannot give Sida Sega, Stampana Chikilsa, and all now. That's why now science it is said that Dushyam, Desham, Balam, Kalam, Analam, Pragatim, Vayaha, Sattam, Satyam, Tadaharam, Avastayascha Pradakvidaha, Sushma, Samikshesham. So every day, just after implementing the treatment, it is your responsibility to identify the dosha and again recalculate the Vikalpa Samprapti and to make modification in the approach. So in the beginning, we treat the patient with Recta Stampano Vaya, Sida Shirodara, Sida Sega, Sida Purambada, Videchana. I hope all of you know the Recta Pitta Chikilsa. Recta Pitta Chikilsa is the very apt, Urthogoda Recta Pitta Chikilsa is the apt treatment protocol for this patient. But always remember, when you add Sida to the eye, when you give Sida property to the eye, Kapha is always there. So if there is an imbalance between the Kapha, there is chance of development of edema, macular edema. So whenever you treat the patient with proliferative diabetic retinopathy, you should be very keen in analyzing the changes that happens. You can go for OCT, you can check the fundus photograph, and in this way you can assess the minute changes that happens. Otherwise, the continued usage of Sida Pragoba, Sidobajaras in the eye for bleeding may leads to some other complication where the Kapha dosha is more actively participating the Samprapti. And you can see after 2 years, you can see Dr. Vishal, can you see this? It is really, it is not only this is not only the patient. We are having a big queue of patient with proliferative diabetes. I don't know how these medicines act at the level of, because in the early beginning of my clinical practice, I was much criticized by modern ophthalmologists because they are getting the feedback from various Shalakya specialists damaging the eye, and they were much criticized. The question they asked was, you are pouring something over the eye, you are pouring something over the head, and how it affect the eye, how it cause correction in the eye, how it affect the eye, how the patient can enjoy vision, because you are pouring something over the eyes. It is not inside the eye, and you are something given to the stomach internally. How it affects the eye? It was criticized. I was criticized into 20 years back, and I generated a hypothesis that my null hypothesis was the medicines pour over the eye and the head is not at all beneficial in the management of diabetic retinopathy. With this null hypothesis, I traveled 25 years. And now after 25 years of my clinical practice, with all this evidence, I am there to ask how the invasive techniques, intravitreal injections and laser can only cure the eye. If you are not caring the body, how you can clear the pathology that happens in the eye? So whatever we are giving to the patient internally and externally, these are having miraculous effect in the eye. And it is our responsibility, not only my responsibility, it is our responsibility to find it out how it acts in the eye rather than these injections and laser. And you can see this is the left eye of the patient in 2016. You can see even after repeated pan-retinal photocoagulation, there is profuse hemorrhage in almost all quadrants of the retina. Again, is left eye. And again, there are fibrous tissue. You just look. So acne, according to the concept of Ayurveda, acne is not at all good for eye. That is why I feel these lasers damage the eye, because in every laser sitting, there may be an increase of 20 to 30 degree temperature in the eye, which may again provoke the blood vessels in the eye and which may lead recurrent bleeding. This is why pan-retinal photocoagulation is not an effective method according to the concepts of Ayurveda. And that's why our concept Sandana and Skandana is much beneficial to the patients with profuse bleeding in the eye. This is the photograph after 1 year. And you can see after 2 years, almost all vessels relieved from the scene. The rectopita is completely relieved from the scene. You can't see any single new vessel here. You can see only fibrous element. This is what we can provide, Ayurveda can provide to the suffering society with diabetic retinopathy. And we can't stop the treatment. We can't stop the treatment in this moment. Again, we should advise the patient to adhere with Ayurvedic treatment to avoid further progression of the disease, that is traction retinal detachment. When this fibrous element grow much more in the eye, there is traction, and finally the retina will be get detached totally. In order to avoid that, you can continue the treatment. There are various measures that we can provide to the patient in order to so as to avoid the traction retinal detachment. The patient is not at all free from Ayurvedic treatment even after the regression of all vessels over the fundus. That's why I told you, this is a single case. There is a big queue of treatment. All patients with PDR, they are very happy. But one important point that is to be clear, we need adherence of the patient. The patient should have to stick on to Ayurvedic treatment. We should have regular follow-up. And again, the patient should have to keep a very healthy mental status. That is very important. The patient with emotional variations can also cause some sort of recurrence. So all these things to be cared very well in order to maintain the vision in PDR patient. And I assure Ayurveda is the ultimate and internationally challenging treatment protocol, if you accurately understand the samprapti that is happening in every moment of your treatment, and if you are accurate in designing the treatment line, and if you are accurate in providing the preventive care even after the cure of that particular situation of the patient. And again, I invite your attention to another case, that is NPDR with NPDR, that is non-proliferative diabetic retinopathy. This is the early beginning. This is the early beginning of diabetic retinopathy. Sometimes the patient may not have any visual symptoms. There may not be a visual failure, diminution of vision. The patient is healthy, but after screening, you can see dot and dot hemorrhages, exudates in almost all quadrant of the retina. So this is the best time to start with Ayurveda. Otherwise, you can start even the patient approaches you in the very beginning of diabetic retinopathy to prevent diabetic retinopathy. You can see this patient. His name is Shivadasan. He is 50. He is non-type 2 diabetic patient, and he started diminished vision in March 2019, and he consulted AIMS Delhi in March 2019. And he was given intravitreal injections of Avastin 7 number, 4 numbers in the right eye and 3 numbers in the left eye. And in May, after 5 months, March, April, May, he shifted to another center in Delhi and consulted the doctor there, and he was given steroid from that doctor. And again, he felt much discomfort with his vision. He approached Government Ayurveda College in July 2020. After 3 months of modern medication, the vision reduced to 6/24 and 6/36. Intravitreal injection, it is the advent. Recent times, it is used by many of the ophthalmologists, and it is really very good in reducing the edema. But the main problem with intravitreal injections is its short half-life. It can provide relief to the patients only for 2 or 3 months. Again, the patient has to repeat the injection. This is the only problem with intravitreal injections. And I do feel Dr. Vishal will explain all these modern aspects in his presentation. So let me skip all these things. And this is the details of modern intervention that provided to the patient. You can see the time is limited, so you can see in addition to macular edema, there is subretinal fluid. You can see subretinal fluid. Here is a black line, that is subretinal fluid. So in both eyes, there are subretinal fluid, and he is treated. And when he approaches Ayurveda College, after all these injections, his vision reduced to 2/60. That is, he's blind, somewhat blind, both for near and for distant. And this is his OCT. You can see edema, subfoveal edema in this patient. And this is the fundus photograph that we have taken using our fundus photograph. And he is treated with Punarnavadi Kashaya, Chandraprabha, Triphala, and Churna internally. And he was, when he was admitted, Damnyamla Dhara was given, Takradhara was given, and Virejana was given. These are the treatment packages that we provide outside the eye and over the head and internally. Not in no invasive techniques in Ayurveda, but it is really wonderful how it acts in the eye. You can see after 1 month, his vision improved to 6/36 in both eye, and his near vision 6/24. You can see the difference in the fundus picture. You can see the hard exudate, it is somewhat absorbed. This is the photograph just after the admission, OCT. And you just see on 13th April, after 9 months, his vision improved to 6/12 and 6/9. And best corrected visual acuity is 6/12 and 9 and 12 and 6. His both distant and near vision improved significantly. And this is the fundus photograph after 9 months. And we got a review on 28th October, 1 month back. And I'm really happy to announce that he's having a very normal vision now, 6/9, 6/9, and N6. I'm really proud of being an Ayurvedic ophthalmologist in treating the patients with diabetic retinopathy. You can see the picture somewhat normal, no? Almost all had exudates and edema. This is before treatment. This is after. You can see this is before treatment. This is after treatment. And this is the left eye before and after. You just see the OCT picture. You can see these are the retinal layers. These are the, when he approaches, you can see a bulge here because of edema. Now it is absolutely normal, and his central macular thickness, it is somewhat less, because I hope it is due to the injection or some degenerative changes that happens at the glial layer of the retina. Anyway, he is maintaining a very good vision. Within 1 year, we treated the patient for 1 year and 4 months. Modern intervention was 1 year and 5 months. And the outcome, it is incomparable. What Ayurveda can provide to the patient suffering from NBDR with macular edema, it is really fantastic. And I do feel these are the standard treatment protocol that is to be get standardized and to be spread all over the world to get some relief to the patients suffering from diabetic retinopathy. And again, I wish to share some more slides about the contradictory treatment methods, that is Tarpana. Tarpana enhance neovascularization. Tarpana is a procedure where we hold some oil, especially ghee, over the eye. And this is totally complicated procedure, and we never encourage any person to do Tarpana. Patients with diabetic retinopathy. A 51-year-old male approached for consultation when he was advised cyclocryotherapy in order to relieve pain in the eye because of neovascular glaucoma. He's a patient who is treated somewhere else. It is not by me. He is treated by somewhere else. But the most dreadful thing is he took continuous treatment from Ayurvedic center. He was suffering from NPDR in 2008 and took Avastin and laser 1 course in 2008. After that, he shifted to Ayurvedic management. From 2008 to 2014, he continuously took Ayurvedic treatment. Now you just imagine the vision. He totally turned blind in 2014. He turned blind into why this happens, even though we are provided with miraculous treatment procedure, why this happen in Ayurveda? And this is only because the lack of knowledge to understand the retina, the lack of knowledge to make the Vigalpa Samprapti, and lack of knowledge in providing an accurate treatment plan to the patients. This is the initial photograph. You just look, the patient, the last patient, when I explained to you, he's having much more retinal pathology. But here it is somewhat less. It is very minimal. In 2008, it is very minimal. And he took Ayurvedic treatment from some other center. And the treatment provided to this patient is Segam, Anjanam, Talabudichil, Dhanyamlam. These are the treatment provided to the patient. And finally, the patient was not satisfied. After 6 years of regular Ayurvedic treatment, the patient shifted to another Ayurvedic center. He shifted to, and this is the only reason why modern ophthalmologists never appreciate Ayurveda, because most of us are creating blind patients because of our misappropriate understanding of the diabetic retinopathy in terms of Ayurveda. It is not because of Ayurveda. It is only because you are wrong in understanding the disease and you are wrong in making the plan. And the treatment provided to this patient is Bhumya, Valagadi, Gulgul. I don't know why Gulgulu, Panjavala Churna, Ashodana, Pushpabandhana, Pindi. All these treatments, I hope it is not sufficient enough to meet the need of diabetic retinopathy person. And finally, what happened, you know, the vision may decrease and the edema increased to 682 millimeter. And you can see the traction element. And finally, this is what happened after 6 years of Ayurvedic treatment, and the patient shifted to another Ayurvedic center. You just imagine the faith, the belief of Ayurveda. And we are damaging the persons who believe in Ayurveda because we are not ready to correct ourselves. Okay, the treatment provided to this patient is 45 days of Tarpana, 45 days of Tarpana of 2 courses. Total, the patient underwent 90 courses, 90 days of Tarpana, and the last day, 90th day of Tarpana, the patient developed very severe pain in the eye, and he was referred from that institution, and he was diagnosed neovascular glaucoma, and cyclocryotherapy was advised to relieve the pain from the eye. And only at that moment, the patient approached me. I was really very sad of Ayurvedic management of this disease. And the patient was treated with Triphala-Kwada, Gulgulu, Segan, Jaluga, Avacharana. Anyway, cyclocryotherapy is avoided for this patient, and his vision improved to 2/60. Even in the last moment, with traction retinal detachment, our medicines, if it is accurate, it will act and give the patient little bit benefit, at least the ambulatory vision to move himself in his surrounding. You can see the reference letter. So a thorough understanding of Ayurvedic principle is the minimum need to manage diabetic retinopathy. You should thorough with the basic principles of Ayurveda. You can see even the specialists who are having PG degree are not focusing the Vikalpa Samprapti, not focusing the right plan. They are choosing to treat the patient. This is a case which is managed by an younger Shalakya specialist, and the patient approached me after 5 months of treatment from that doctor. His vision was very good, because when he was advised individual injections, he denied that injections and directly approached Ayurveda for management. And he was treated by the doctor. You can see the right eye, there is little bit edema, and the left eye, it is very profuse. It is 400 and something. And look the package. I don't wish to get into the details of that case. Just listen the package. The patient is provided with Bala Datriadi Taila. Bala Datriadi Taila in a condition where there is profuse edema. It is strictly contraindicated, because you have to treat a case with NPDR with macular edema, just like Shobha. You can treat PDR just like Urthagada Rektabitayan. You can treat NPDR with macular edema just like Shobha, and Thaila in the early stage of edema, it is strictly contraindicated, and what happens is his vision, it is somewhat reduced, and the patient was much disappointed with the Ayurvedic treatment, and he's developed suiciding tendency because he is an unmarried man and an advocate. He couldn't do his work. His vision reduced to 4/60 and 6/60. You just imagine, beginning he is having 6/12 vision in the beginning when he approached Ayurvedic physician, and his vision reduced to 4/60 and 6/60, and near vision less than N6. Totally, he's blind. He's blind because of Ayurveda. So this is why modern ophthalmologists, they are always against us. You can see the edema there. The time is very limited. I hope my time is over. Anyway, these are the supporting evidences. He is treated with Sadyobamana, Takradara is provided, Dhanyamladara is provided, and Virejana is provided to the patient. And you can see just after admission, just after admitted treatment, his vision improved to 6/18. His vision improved to distant vision. There was no improvement for his near vision. His distant vision improved to 6/18. And review after 1 month, you just look, review after 1 month, his vision improves to 6/12 and 6/9, and near vision N12. But the interesting thing is his edema remains as the same. His edema in his right eye, you can see the edema in the right eye, it remains the same, but his vision improved markedly, and he is having a normal vision. So in modern, there's a tendency to maintain the structural integrity. Ayurveda never focused on the structural integrity, even in the presence of lack of structural integrity. If the patient is enjoying a very good vision, that is to be accepted, I feel. So last review. Here, after getting a very good vision, till date there is no reviews. The patient feel that he is completely recovered from his pathology. There is no review. I do feel if he continue this in this manner, avoiding all Ayurvedic treatment, sometimes it may recur. And even I wish to contact him through WhatsApp, but he is not willing to come and see the retina. And this is a photograph of a person who approached For the first time when he diagnosed macular edema, he never go for any intravitreal injections or PRP or any sort of modern medication. And you can see within 1 month, his edema is completely relieved. The treatment provided is Sadhyo, Vamana, Takradara, Dhanyamladara and all. So, and after subsiding the symptoms or after regressing the vessel or after resolution of the complete hemorrhage, the patient has to keep on preventive care. And in preventive care, as our moderator, Dr. Sreejit said, Ilanir Param is the best option for all patients who comes to normal after edema and also after this kind of neovascular regression. So you can provide preventive care to all patients with diabetic retinopathy, Anjana, then Pratimarsamasya, Punarnavadi Kashaya, Tripala, Churna with Kanmada. These all are the preventive measures that we can provide to each and every person in order to prevent diabetic retinopathy. And this is really very interesting case of Harish Babu, who approached us 2011. He was advised for laser and he was treated for only 3 months. This is the picture of his OP ticket in 2011. His diabetes is in poor control. He's having 350 fasting sugar at that time, and his vision is reduced to 6/24. And this is his FFA picture. And you can see there is leak and all, and he's treated in an OPD manner. He was provided Kanmada, he was treated with Sega, Anjana and all, and his vision is reversed. The interesting thing is that I lost his follow-up since 2011 to 2018, even though I tried to contact him many times, he didn't come. And in 2018, I got a review, and it was really excellent. The patient was maintaining the same vision in 2011, what we provide to him in 2018. And it was verified by another retinal surgeon. You can see the comments there. His vision is 6/6, even after 7 years. Without any treatment. He was treated with Kanmada and with some Anjana, Ashodhana in the early beginning, only 3 months. So if we provide an accurate treatment plan to the patients in the early beginning, I hope the result, it will sustain for years. And with this intention to provide more service to the society, we started a project, Jyotirgamaya, without any fund. It's only our effort from the PGs and my colleagues and my friends. And still we are continuing. Around 1,000 patients were registered, and we are following all these patients as a cohort. So to conclude with my presentation, Ayurveda is the best choice for diabetic retinopathy, and accurate Vikalpa Samprapti is extremely very important in the management of diabetic retinopathy. We should keenly absorb the changes that happens in the doshic level at regular interval so as to make difference in the treatment procedure too. A standard guideline for the management of diabetic retinopathy is inevitable. It is inevitable. Anyway, let me conclude. My time is over. Let me thank once more for the whole team and the entire team of Sitaram for giving me this special chance to deliver my experience on this special day, Diabetic Day. Thank you all.
And as always, you give us more and more reasons to take pride in you and for us to feel proud that you belong to us as much as you belong to society. A very quick recap is that, as I've understood in your OPD and as like students like myself, that you go by the clear history, you go by the clear detailed case taking, you also go by the subjective doshic assessment, and you verify it by the objective modern parameter of the ophthalmoscopic examinations, as you have learned easily and you have taught all of us. And then your medications are so simple. There's no secret medicine. It's all easily available and very cost effective also. Your procedures are easily doable and everything is so copy pastable. That's the beauty and the elegance and the efficacy of your methods. There is no secret and easily copy pastable if we put regular hard work. And most importantly, you taught us with example what not to do and not just what to do. So all this makes a very fantastic comprehension and very detailed understanding of the topic. And we know this is not enough. We all know that. We need more time, and I'm sure we would be able to be blessed by your presence in further sessions also. Last but not the least, we should conclude Dr. Sreeja ma'am's session by a gratefulness, a gesture of gratitude and gratefulness to the legendary Dr. K. Shankaran sir, who was her mentor in the college days and who inspired her to get into Bhalataka Rasayana. And the Tridoshas and the understanding went from Kerala. And the legendary Dr. V.J. Mukhopadhyay sir of Banaras in the university, who immensely helped Sreeja teacher in the modern aspects. So without having a heartfelt thankfulness and gratitude to those two legends, I think it would be insane and impolite to conclude this session. Ma'am, thank you very much. And I will have to now hop to one very, very promising Dr. Vishal, who will come across to this venue. To say the least about him, as I spoke to him yesterday, Dr. Vishal is not just a retinal surgeon, had his MBBS from Hyderabad and further fellowship in the same place. He is a great Ayurvedic enthusiast. And the Society of the Medical Care is definitely showing signs of progress when we realize that people of his stature and qualification of such a specialized subject showing interest, trying to bridge the Ayush or the Ayurveda and the allopathic segment. Just as Dr. M.S. Valyatan sir, more than 25 years ago, Padma Vibhushan Valyatan sir, a cardiac surgeon, just as he made the bridge at an academic level, I am so happy to realize that youngsters, well, he's experienced, but youngsters like him are coming up with a very huge professional magnanimous gesture to explore and to find what Ayurveda has to offer. That's a great sign of progress for all of us to cheer about. And I was very particular requesting him, sir, if you would be, listening to Dr. Sreeja ma'am's presentation, so that, as madam pointed out, that there's no much of funding or whatever, there are limitations, whatever it is, bureaucracy or logistics or finance. But I also think there's also an opportunity for us to get to the public and to be of service to the public if any private institution can step in and help such cause without any kind of hesitation, so that we have a society with least and least of blindness incidences. Dr. Vishal sir, thank you for the enthusiasm in Ayurveda. We are all yours, so it's all up to you.
Morning all, thank you for this opportunity, and I'd like to thank Muraleedharan sir for having me on his panel for the talk today. Is one of the legends in Ayurveda. Thank you, sir, and I'm very glad that I am succeeding Dr. Sreeja's talk, because Madam has really brought about how efficiently and effectively Ayurveda can manage diabetic retinopathy. I had a lot of comments and a lot of things to sort of discuss with Madam, because there are a lot of places where we feel a hybrid system of medicine actually works best for the patient, considering what modern medicine can provide and what Ayurveda can provide. I think it's just to think about it, that the combination can be provided to somebody under one roof would be just a fantastic, thing for patients to experience. Having said that, I will just move on to my presentation. Please give me a minute. Right. Are my slides visible and am I audible? Yeah, I think they are visible. All right. So thank you for this opportunity again to the entire team at Sitaram Ayurveda Private Limited, to Dr. Ramanathan sir, to Dr. Vignesh, the entire team for sort of involving me in this talk. I am sort of a practitioner of modern medicine, or I would just call it allopathy rather than modern medicine. Ayurveda is quite modern as well, considering the kind of results it's achieving today. So just to sort of keep the air clear, my talk is predominantly on the diagnosis and updates in diabetic retinopathy. The treatment and management is not something I would be discussing on in this presentation, because I think Dr. Sreeja has very eloquently sort of looked at it and shown us very, very clear results on what can be achieved in Ayurveda, even for the advanced stages of diabetic retinopathy. So I will just be talking about a stepwise diagnosis and protocol which we follow, which I personally follow after my years of experience, and some updates with regards to what we're doing in diabetic retinopathy. So yeah, quickly going through this, diabetes, India is the diabetic capital of the world. We are estimated to reach almost 100 million diabetics by 2030. It's a non-communicable disease, and it's second in magnitude of diabetes only after China. Dr. Muraleedharan sir very clearly put this point through, that stroke, MI, and deep vein thrombosis are the microangiopathy changes with diabetes, macroangiopathy, sorry. Where with microangiopathy, we have nephropathy, neuropathy, and retinopathy, which are very, very similar in the way they affect the body. Diabetic retinopathy in major studies of the country have shown an incidence of 17 to 22% amongst diabetics. And the two main risk factors for the development of diabetic the two main risk factors for the development of diabetic retinopathy are this duration, which is non-modifiable, and the control, which is modifiable. Obviously, hypertension, anemia, nephropathy, and pregnancy, puberty are other risk factors. It's a chronic vascular condition. And as Dr. Sreeja had alluded, sight-threatening diabetic retinopathy accounts for 5% of patients with diabetic retinopathy. This is basically patients who have lost vision or are going to lose vision because of diabetic retinopathy. So this is a very interesting sort of statistic. Just look at the southern part of the country. Dr. Sreeja actually alluded to this, but this is sort of a breakdown of the districts in the country. And look at the heat map at the bottom. It's maroon, which is very, very high incidence of, very high prevalence of diabetic retinopathy. So this is something which we sort of face in the southern part of our country, considering our dietary habits and the way we work. But fortunately, whether it's Ayurveda or allopathy, homeopathy, whatever is the system of medicine, it's quite strong in the southern part of India. So we as a team, as a joint team, can sort of handle this load of diabetes and ensure we have, a blindness-free society. The pathology is something which Dr. Sreeja has just touched upon. I'll just go a little bit into it. Diabetes predominantly in the microangiopathy side affects the capillaries at the retina, kidney, and the blood supply of the vasa nervorum in the brain. The capillaries have supporting cells called pericytes. Capillaries are single cell, as you can see in the slide. It's a single cell layer with blood inside. And then you have pericytes which support the capillaries. So what they do is there is a pericyte loss because of ischemia. Along with that, there is basal membrane thickening, endothelial cell damage, changes in the RBC shapes, and an increased platelet stickiness. So Dr. Sreeja was speaking about the way she uses Ayurveda at this level, at sort of a micro level, to arrest the problems with diabetes. And as you see, there is an endothelial pericyte ratio in diabetes, which is lost because of damage. And this foamy nature of the basement membrane, where it becomes vacuolated, thickened, and the endothelium starts to trigger off clotting in the capillaries, which leads to capillary dropout areas. So diabetes predominantly presents as two pathologies: microvascular occlusion, where there is a loss of blood supply leading to shunts, leading to cotton wool spots, which is basically, they look like cotton. I will show you how they look. They're basically ischemia, that is a lack of blood supply in the first layer of the retina, which is the nerve fiber layer. And then VEGF is released, which is vascular endothelial growth factor, which is responsible for development of new vessels. And as we saw in one case of Dr. Sreeja's, there was rubeosus iridis, which is nothing but neovascular glaucoma, and proliferative retinopathy, of which she showed quite a few pictures. The other side of it is leakage. So because of the loss of pericytes, you can see there is a lot of leakage. This is known as the inner blood retinal barrier. Normally, in all of our eyes, the blood and the retina is kept separate by the inner blood retina barrier, which is the capillary wall. But because of the weakening, there is leakage at the level of the inner blood retinal barrier. So you have retinal edema, which is called CSME, along with hard exudates. And then you have microaneurysms, which are nothing but small covers or pouches of the retina, and then hemorrhages, which are bleeding spots in the retina. These are seen in the earlier stages of retina. So why do we lose vision in diabetes? What are the reasons why we lose vision in diabetes? Obviously, there is a faster development of cataract. You see the image to the left, there's a clear lens, relatively clear lens. With the right, you have cataract. I'll just show you a picture of a normal retina. This is how a ophthalmoscopic retina looks, or a fundus photo looks. You see a clear central foveal reflex, good blood vessels with a 2:3 ratio and an optic nerve, and then a lot of capillaries in between the arteries and the veins. Let's look at how a diabetic eye looks. Look at this picture, lot of cholesterol crystals and lot of multiple hemorrhages which have developed over the course of worsening of diabetic retinopathy. This is an angiogram, like we do an angiogram for the heart, but this is an angiogram of the eye called the FFA. I will be showing a few more images in the slides to come. You see a loss of central area. The central area has become completely dark. And this is normally not a good sign. These are the patients where despite treatment, despite no macular edema, you do find poor vision, because this is the ischemic maculopathy side of diabetic retinopathy. This is a very, very severe eye where there's a lot of hemorrhage in the vitreous, which is a gel in front of the retina, and clots of blood, altered blood on top of the retina with very, very poor vision. And this is almost end stage disease, which is actually a surgical nightmare for us, where we have a lot of difficulty in sort of regaining the anatomy of the eye. And even after regaining, like Dr. Sreeja said, it's quite challenging to give functional vision to them because of the amount of ischemia the retina experiences. We'll just look at some of the findings. Like I said, outpouchings or small pouches of the blood vessels in the earliest stages. These are called microaneurysms. And then you have hemorrhages, which are again exudative changes. You see, this is just like a flame. So this is called a flame-shaped hemorrhage. This is just a dot, so it's called a dot hemorrhage. This is like a tomato ketchup dropping on a table. That's why it's a blot. So this is called a blot hemorrhage. And I don't need to explain this image. Too much of cholesterol. You can see tremendous amount of cholesterol, and you can see these small red lesions which are leaking. These are the aneurysms leaking continuously. And this pattern of circular cholesterol around an aneurysm is called cystinoid retinopathy. Moving on to slightly more advanced changes. This is the ischemic change I was talking about. This looks like a small wisp of cotton. So it's called a cotton wool spot. It's because of lack of blood supply to the first layer of the retina. These last for 4 to 6 months based on how you control your diabetes. These are much more subtler changes which we sort of notice. This is a loop, as you can see, as the name suggests. This, you see, this is a vein of the retina. It is thick, thin, thick, thin. This is called venous beading. And a furthermore advanced version of this is called sausaging or venous segmentation. Here you see the vessels are red, but this vessel on the top is white. This is a retinal arterial obliteration. This is a gross sign of ischemia. We move to IRMAs. IRMAs are very, very subtle signs again. These stand for intraretinal microvascular abnormalities. Normally, as you see this picture, you go back to this picture, the artery and the vein is supposed to meet at the capillary. You can see on this center, this is the artery, this is the vein. It is supposed to meet at the capillary. But when you go to an IRMA, they start to meet before the capillaries. This is because they want to open new areas of blood supply. So you can see that the arteries and the veins are meeting before the capillaries. And these are not good signs. They indicate that there is a huge amount of ischemia, that is lack of blood supply in the retina, and it requires some sort of therapy to sort of stabilize this lack of blood supply. This is the end stage, which Dr. Sreeja was talking about, proliferative diabetic retinopathy, which is very typical CFAN neovascularization, multiple hemorrhages. And you can see this is called an NVD because it's occurring at the optic disc. This is called an NVE because it's elsewhere, and there is some pre-retinal hemorrhage already happening. There are 3 conditions which are called advanced diabetic eye disease by the DRS study. Presence of a vitreous hemorrhage. This is a wide field image, which I'll be talking about. You can see a black hemorrhage here in the gel in front of the retina, or the presence of tractional retinal detachment, again, very, very advanced end-stage disease because of the fibrosis, which Dr. Sreeja was alluding to. And then you can see rubiosis iridis or neovascular glaucoma. These three conditions are alluded to as advanced or end-stage diabetic retinopathy. We look at the algorithm for the diagnosis of diabetic retinopathy. You have the presentation, you have risk factors, you have systemic status, you have visual function, clinical findings, and then investigations. I'll not touch management like I mentioned because we have already seen a wonderful presentation from Dr. Sreeja regarding how it can be managed. When you look at the presentation, predominantly acute vision loss is how it presents. Like I said, cataracts, bleeding inside the eye, or detachment can be the cause for this. The vision loss can also be gradual in some cases because of cataract or macular edema. Dr. Sreeja's patient presented with pain, so that's one of the harboring signs of neovascular glaucoma. There can also be some patients who just come in saying, I occasionally lose vision or I'm not able to see colors. And that's where we sort of look at optic neuropathy as well as one of the presenting signs of diabetic retinopathy. Like I've just touched, there are a few factors which you cannot modify. You cannot modify puberty, pregnancy, or the duration of diabetes. But what you can surely modify is hyperglycemia, which is blood sugar control, and hypertension. The factors with variable evidence include dyslipidemia, nephropathy, anemia, smoking, high salt intake, and glutathione drugs. What I do as a protocol is I will just show you. So these are the tests I normally look at in every diabetic patient. If it's an expected diabetic, obviously HbA1c is the most important metric. Hypertension, lipid profile, and urine for microalbuminuria are very, very important. Urine for microal and lipid profile are essential for diabetic macular edema. We treat a lot of patients with very, very poor renal function tests and they don't respond to treatment. This is predominantly because of the severe ischemia diabetic nephropathy is associated with, along with diabetic retinopathy. Complete blood picture is very important because blood cancers like Professor Muraleedharan sir was alluding to has a very, very tricky knack of presenting with diabetic retinopathy. Very severe worsening of diabetic retinopathy is noted in patients with leukemias and lymphomas. So we always do that. Apart from that, complete blood picture also gives us a picture of anemia and platelets. Anemia is a big risk factor for the development of diabetic macular edema. We've seen a lot of patients where just without giving any sort of injections, we just control the anemia and the edema goes away. So it is a proven sort of risk factor for diabetic retinopathy and more importantly, diabetic macular edema. We look at visual function. I think what vision we record across be it Ayurveda, allopathy or anything is a very small minuscule of what visual function is. The Snellen visual acuity is only a function of central vision. Peripheral vision, like Dr. Sreeja's presentation aptly said, can be tested by perimetry, but we also have to look at the pupillary reaction to see how the optic nerve is. Near vision is a very important indicator of macular health. Color vision, contrast sensitivity, and the other functions of vision which can be evaluated along with the help of an ERG are very, very important things in assessing visual function. Photopic negative ERGs are one of the latest ERG responses which people are looking at in early diabetes. It is being used as a tool in patients who don't have any diabetic retinopathy to sort of pick up changes, the earliest changes of vascular malfunctioning and poor retinal function. That's one of the recent things which are catching up in the ERG. Clinical findings, pupil dilatation is something which we always experience as retinal physicians. It's basically a marker of diabetic autonomic neuropathy. Over the years of neuropathy, diabetes also affects the parasympathetic system. So you have poor pupillary dilatation. That itself is a marker that you're in with a very, very chronic case. Grading of cataracts, diabetics are the few patients where they can have an acute onset of cataract within a week. I repeat, within a week, within 10 days, because they can have very severe fluctuations of sugars and that can lead to temporary cataracts or temporary lens clouding, which can sort of recover over diabetic control. The grading of diabetic retinopathy and macular status is very important. We follow this simple grading by the International Disease Severity Scale, where only microaneurysms is mild, more than microaneurysms and less than severe is moderate. The 4-2-1 rule, where 4 quadrants of 20 plus hemorrhages, 2 quadrants of venous bleeding, 1 quadrant of IRMA. Any one of this is in severe, and more than one is considered very severe as per ETDRS. And proliferative is presence of neovascularization or vitreous and pre-retinal damage. Diabetic macular edema has multiple classifications now. You have no apparent thickening or some apparent thickening, which is present or absent, and then you have mild, moderate, and severe based on the center involvement. But this is all based on ophthalmoscopy. Now, the more important classification is based on OCT, where it is center involvement or non-center. This is the time-tested ETDRS classification for CSME, which I will just skip. This is just to take a look at a normal retina and then how diabetic macular edema looks. You can already see that some laser has been done, but despite of that, there is a huge clump of hard exudate at the macula. We look at a few investigations now. Optical coherence tomography is a non-invasive test. You can see this is a normal scan where all the 10 layers of the retina are seen. It allows to assess the macular status. Now there are markers to assess ischemia as well on OCT, but previously edema interaction is what we were looking at, and it's used as a follow-up therapy for intravitreal injections. You can see gross edema here, very, very severe in all the layers of the retina. You can see some inner retinal layer edema as well, which is not a good sign. It means chronicity is kicking in. And here you can see very, very gross traction. Here the vision is extremely poor, and these are the cases where a sort of a collaboration would really sort of look at, because we do operate on these cases, but the functional outcomes are very, very variable. Some of them do very well, some of them don't. So arresting the anatomy through a surgical approach and arresting the core issue of diabetes through Ayurveda would be something which I would be very interested in looking at, so that at the platelet level and at the endothelial level, Ayurveda seems to be a sure winner with response to treating these kind of, preventing the onset of these kind of diseases. And if there is a sort of requirement for anatomical realignment, then surgery can certainly be an option in the presence of, cross departmental medical approach. Fluorescent angiogram, like ma'am was alluding to, the one on the left is something which I have personally shot. This is a very clear-cut, normal fluorescent angiogram. It is a time-based exam, but you see on the right, multiple bright spots, which are all microaneurysms, and the central dark area, which is normally called the foveal avascular zone, is enlarged here. It is crenated, it is notched, and you can see the comparison. You can see a normal foveal avascular zone here, but it's very, very large here. You can see it's almost extending up to here. You can see all these looping and beading very clearly seen. You can see some amount of enlarged blood vessels. Look at the bottom area, again, ischemia. Not a good sign. Despite the patient having a normal retina, you can have poor vision in these conditions. Again, this is how the neovascularization of the disc, the proliferative DR appears on FFA. It's quite a clear-cut sign, and now almost outdated because it's invasive. So we do a clinical examination, and based on that, we diagnose. B-scan, like ma'am was said, is very essential, and when you cannot see the retina because of cataract of blood, gives you the status of the bleed, status of the retina, and the status of the optic nerve. A severely glaucomatous optic nerve can be diagnosed. You can see some traction here. You can see vitreous hemorrhage here with the blood line, the posterior vitreous detachment. Very, very typical signs in diabetic retinopathy. I'll just quickly move on to some updates. The one on the left is not an update. The one on the left is the standard, where you have type 2 diabetes at diagnosis and type 1 diabetes at puberty, or 5 years from diagnosis is when DR screening is required. But the image on the right is something which we have published as part of the Diabetic Retinopathy technical guidelines with the Queen Elizabeth Diamond Jubilee Trust, where we looked at what type of follow-up is required. And if there's no diabetic retinopathy, an annual follow-up is required for the fundus. But if it's mild, it's 6 to 12 months. I'll explain why there is a range. Moderate is 4 to 6 months, severe is 2 to 4 months, and PDR is treated within 4 weeks. The asterisk at the bottom is very important. We sort of look at most of the literature saying that diabetic retinopathy follow-up should be based on certain number of months based on the finding in the eye, as you see on the left. But here you see that if the poor glycemic control exists, or the patient is pregnant and in the first trimester, I would rather see the patient more frequently, because the glycemic control is going to be poor and the diabetic retinopathy worsening is going to happen faster. So a diabetic retinopathy finding plus a glycemic and systemic control based follow-up would work much better for patients, and much better preventive care can be given in this screening protocol. Now, mobile phones are something which we use everywhere. So now diabetic screening is happening in a very mobile way. This is sort of a very bulky device, to be honest, but this is an update. You have handheld cameras where you can directly take the picture holding it in the hand without any drops in the eye. They're non-mydriatic. Or you can just put your phone onto a device and click a picture. So this is as good as a small, iPad. You can just put it into your bag, go anywhere you want. No drops required for the patient. Attach your iPhone or whatever phone you have, and then take a picture. So this is something which is sort of decentralizing or making it like a water supply service where anybody anywhere can screen for diabetes, and the training curve is very low here. Anybody can learn this. So this is something which we are sort of involved in. We have a couple of projects going where we have diabetic retinopathy screening happening, and I'm mentioning that we are having projects primarily to help people understand that it's a feasible thing. It's not something just for research basis. It can be done on a real-time basis. Wide field imaging is catching up very, very quickly. This is a patient of mine who had diabetic retinopathy. So normally we would only see this zone. The central zone is what we would see, and you would see some amount of hemorrhages. But now if you see a wide field image, wide field means you see the entire retina in one shot. Normally when we examine the retina, we have to look at different zones by asking the patient to look up, look down, look right, look left, and then look straight. But here you see in one shot, I'm able to see the entire retina. And if you see carefully, the number of hemorrhages in the sides of the retina is very multiple, a huge number of hemorrhages compared to the center. You do see some hard exudates and cholesterol accumulation in both the eyes, but you can see that the periphery where I'm pointing my mouse now has multiple hemorrhages. So now slowly the grading of diabetic retinopathy is changing, and not just the central retina, but the peripheral retinal changes are also being involved to come up with new classifications of diabetic retinopathy. A patient who has undergone laser, fresh laser, that appears like this. This is a more advanced case where you have very severe traction at both the eyes, very poor vision in both the eyes. You can already see the blood vessels are sort of ischemic. So our functional results are again questionable, but anatomically we will be able to sort of operate. You can see again a sclerosed vessel here. There's no blood flowing in this. And this is where I feel Dr. Sreeja's presentation has been fantastic. A lot of take-home points for personally me to understand what sort of scope Ayurveda has. This is an operated eye, which I have operated with a good result. Patient has good anatomical outcome in his right eye. What I want to show you here is a bubble of silicone oil which we use. This is sort of detected after surgery. And the left eye is something which is extensively lasered with some amount of hemorrhage, which is not because of active PDR, but because of traction. But he's maintaining very good vision in that eye as well. He's 6'12" in one eye and 6'9" in the other, and he's been like that for a while. I'll just move on to OCTA, which is the new tool in the block. So you've seen the FFA where we give a dye into the eye. It's an invasive test like Dr. Sreeja was mentioning, but we have the non-invasive angiogram as well, which is the OCTA. Image D is the image of the FFA, but image A is the image of the OCTA. You get similar detail. Actually, you get more details. What you do is you slice the retina into 4 levels. The level 1 is the upper part. The level 2 is the upper middle. The level 3 is the low middle. And the level 4 is the low. So you have a non-angiography, non-invasive angiography where you can get all the changes regarding blood supply of the retina without giving any dye. It's an expensive tool, but it's something which is catching up. The understanding of the tool is just picking up now over the past 2 to 3 years. You can see a diabetic case where you see a normal case where the central area is limited, black, well-defined. You see a diabetic case, the area is a large area of black where there's no blood supply. Again, you have all these vascular changes, you have dropouts, you have darker areas which suggest aneurysms. So this can sort of explain why the vision is poor in diabetics. You can see the OCT, not much edema. So you wouldn't understand why the vision is poor here. But you look at the OCTA angiography, you very clearly see why the vision is poor. So obviously because of a lot of ischemia which is set in. This is a proliferative case. You can see an NVD here. You can see a lot of capillary dropout. You can see a lot of kinking of vessels. These kind of patients are very, OCTA is very beneficial because they also have nephropathy in them. So you cannot do an FFA considering it to be a very relative, not a contraindication, but a relative test which we should avoid because of the dye we use. So OCTA is a non-invasive test which can be done at every visit, and you can get all these findings quite easily. You have wide field OCTA as well coming in. So I think that may be a game changer for all of us, including Ayurveda physicians in the future, to monitor the treatment. Just give me 1 second, please. I'm sorry. So this was the teleophthalmology update which I wanted to give you. This is a model which we are currently running. And what teleophthalmology basically is you can sort of use, you can see the device at the middle. It's a phone-based fundus camera. So what you could do is you could put these devices at any sort of center, a primary healthcare center, or any small clinic or any place where diabetics come. And without drops, a diabetic who comes for regular checkup would also get his eye screened. So the preventive care is very, very opportunistic, and it's very efficient. This is our model where we do it with the government of Telangana in Hyderabad. So people come to these slum clinics for free diabetic medication, and they just come and get an eye checkup done, eye photo done. Once the photo is done, if it is diabetic, through the cloud, we have a image reading center at our hospital, and we read the images, and immediately we counsel the patient. If it's a referable diabetic retinopathy, he's immediately called for a checkup. If it's a mild retinopathy, we tell him about the systemic control and ask him to come back accordingly. So this sort of decentralizes diabetic retinopathy treatment and screening again at the preventive level. This is something which is picking up over the last couple of years, and a lot of work is going on. This is surely an update which we should all sort of take to and see if we can do it in Ayurveda as well. It'll be quite useful. Last is artificial intelligence. I think this is the hot topic today in all of science, and diabetic retinopathy is the most studied disease under AI. Here we have a lot of automatic grading by machines of the grade of diabetic retinopathy, which can be used by all of us, including Ayurvedic physicians, to sort of have pictures taken remotely, the grading coming in. So let's say you screen 1,000 people, the artificial intelligence protocol algorithm would grade those which require your care. So the efficiency and it's time of the Ayurvedic physicians, especially the very busy ones like Sreeja ma'am, where time is of essence. The screening can be done, and the patients who require urgent care can be triaged, and they can be taken up for care immediately. So this is sort of really big. I've just put up a few headshots of papers. This is the largest paper, which is from the National Health System in UK. In India, we have a lot of big institutes working on it with Google and Microsoft. This is something for the future, which all of us should look at, and all of us should certainly embrace, so that we can sort of actually globalize diabetic retinopathy, like Dr. Sreejit was mentioning. So I'll end my presentation here with a namaste, and thank you for accommodating me in this lovely session this morning. And I'd again like to thank Muraleedharan sir for giving me this opportunity. I'd like to thank Sreeja ma'am for setting up the stage for me, and the entire Sitaram group for their opportunity of involving me in this talk. Congratulations to them on the lovely journey over the last 100 years, and we wish that we collaborate and we bring about the best possible systems of medicine we can with regards to health in the years to come. Thank you so much.
Thank you very much, sir. Thank you very much, Dr. Vishal Govindhari, sir. It has been definitely enlightening for many of us, the latest trends that you have brought in. And the most striking one, there are many striking points in your presentation, but the most striking one is the AI usage in about 30,000 patients they have screened so effectively. Is definitely going to be a game changer, as you had mentioned. And the most appealing, at least for me, was the service-oriented presentation about how the slum clinic base hospital is nothing short of a war room. I felt like being in a war room of salvaging people's vision. And I must conclude with a clear note that Dr. Vishal, from his childhood, this is what I have been conveyed, not by him, by somebody very reliable about him, that from his very childhood, he had a very clear passion towards eye care. And he was very insistent to his family that if he's becoming a doctor, it has to be an eye doctor. And then I realized by yesterday that from a level of taking this as profession, it went to a level of passion, and then now it's to the level of mission. This is what is the very special hallmark of him and all the other 3 faculties who have joined us. Thank you very much, sir. I hope Dr. Sreeja ma'am and yourself can have a clear professional understanding and interaction, and that will be great for the society. I'm sure it can be a good role model for the world also, if both of you can combine by all possible professional means. Thank you very much. I would take the next step towards inviting Dr. Gopi Krishna, sir. Obviously, as always, I would refrain from making formal statements and the information that you already know about him. Dr. Gopi Krishna, sir, would be perhaps incomplete in his profession if I don't mention the great, legendary, 93 years old, the Bhishma Acharya of Rasa Shastra, Siddhi Nandan Mishra, sir, Professor Siddhi Nandan Mishra, sir, because he is the ultimate authority in Rasa Shastra. All of us know that from the academy. I must also continue with utmost reverence and respects to all those great Siddhas in the Sri Shailam forest belt, where Dr. Gopi Krishna, sir, took the audacious and the daring step to get into that forest. And there are many things I cannot speak here because the information I convey to you may be too overwhelming. But I must also communicate to you that the information conveyed to you is very credible. He may be shy to convey this, but his very dear friends, Dr. Raghavendra Udupa, Dr. Ajay Sadanandan, they are very darling brothers of mine for a very long time, 20 years I know them. So I totally rely on the information. And I have been conveyed by them is that if you really want to learn Rasa Shastra in the authentic manner, you have the person, the faculty in front of us. Not only he is blessed by teachers of the highest caliber, as I mentioned, Mishra sir, the Siddhas in the Sri Shailam forest range, he has a great penchant to help his students, even to the extent of sponsoring some financial aids to students to do some very creative level of research in the Rasa Shastra. And he has a great set of students who are following him. The same way, the profession becoming a passion and becoming a mission. Dr. Gopi Krishna sir is not just satisfied with activities and samples that he gets in labs or wherever the market. He is a field man. He goes to the field, goes to different locations with the Himalayas or whichever, even outside India, to have a direct feeling of what the materials are like. So he takes things full throttle, 200%. And what is really great about him is his penchant to train the next generation doctors. His intention to popularize Portly method that is getting as a cultural revival. I was looking at his WhatsApp DP yesterday. I just have contact with him for 2 days only. And I realized there's a caption, his DP reads like in WhatsApp, born to lead. I thought it was a bit incomplete because maybe it is complete. Born to lead the revival of Rasa Shastra. Maybe that's a better DP perhaps. Because we take a lot of comfort and solace in the fact that very special and secret knowledges of Rasa Shastra would have gone here and there, but for not people like him. He comes from a very affluent allopathy, modern medicine, I'll correct that, thanks to Dr. Vishal, not allopathy, but modern medicine background. But you may feel very strange, somebody from that thick background coming to the Ayurvedic fraternity, that too a very Niguda Shastra, as it may sound like, Rasa Shastra, and such a complicated, deep and diverse topic. But that's how it is. Perhaps every life has a purpose in its own measure. And I think this would fairly summarize that we are very blessed to have you, sir, here. Again, a disclaimer, we know we have shortage of time. Sir has already compromised some of his valuable clinical time of Sunday. Even if it may appear short for you, please be assured, he has assured us that he would bless us with his class time and again in this coming year. Sir, we are all over to you. We are all yours.
Thank you, Dr. Sreejit. And I'm really grateful and like to congratulate the event for the 100th anniversary and the Sitaram Pharmacy, very dear to me. And also Ramanathan sir and Dr. Vignesh for honoring by my presence here over this elite stage. So my moderator, Dr. Sreejit, it was really great words of introducing me to the crowd. Thank you very much for it. And also I salute Muraleedharan sir here. I'm able to say him, and I'm very happy to share a few of my thought processes. because once we speak about using some of the Rasaoushadhis in a normal person or any of the ill patients, it's always people have a wide open eyes to see you're using metals and minerals to the humans. Then they find a sort of a question marks, lots of questions. Possibly you get puzzled away because you want to use metals and minerals in medicines. But it's more amazing again to see, because today my presentation is on the renal issues where you are dealing with the Rasaoushadhis. It's something like a double dhamaka, where we are going to deal with the renal complications related to that of the diabetes and manage them with that of the Rasaoushadhis. So let me come up with a few of the processings of my presentation today. So today I'll be dealing is about the Rasaoushadhis in diabetic management, especially in the nephropathy. I might not be dealing with all the other details regarding the conceptual part of the diabetes and the other things, because it's already been excellently discussed by all the experts in these 2 days on the event of the World Diabetic Day. So I'll be straightforward stepping into the topics of diabetic nephropathy. Basically, to speak, there is no much difference in the pathogenesis based on the nephropathy as retinopathy or any of the things related to diabetes, because I've just heard about Sreeja ma'am and also sir speaking of Vishal sir speaking about the retinopathy and its complications and the management, other aspects. The pathogenesis is almost the same. The key role here for us to manage in the nephropathy is try to manage the diabetes. It's not like the nephropathy which we need to focus on. We need to focus on more about the diabetes, because uncontrolled diabetes is leading to nephropathy. So Nidana Parivarjana for us Ayurveda, it is very strict, and for us the Nidana here is the diabetes. So try to say that in case if we can really manage with that of the diabetes, many times the nephropathy, in case if it is not altered in respect to its anatomical aspect, then the physiological aspect of the kidney could be much reversed most of the times. But in case if there is a parenchymal change or there is an organic change in the kidney, then reversing it is a bit challenging. It might be possible, or sometimes it might not be possible. It's not like all the cases of nephropathy are easily treatable and curable. They are highly challenging. And it's not like I would like to recommend all my patients to undergo dialysis or ask my patient not to go for dialysis. Either the way it depends on the situation and the condition wherein we go with. So with this background, I would like to step into actual phenomenon, what's actually going on in diabetes and what is the treatment which we are supposed to give to the patients here. And salutation to the God, who is the attribute of the science to the world for the betterment of the humanity, Lord Dhanvantari and Lord Shiva. I am specific towards the rasa preparations, where the Adibhishek is considered as Lord Shiva, who is enumerator, a board of knowledge for the Rasa Shastra. So herein wherein the person has come across, it's not alone, only the sweets which is taken has made him to land up into diabetes. There are many other factors which has landed up. The stress factors, the drug induced, many of the factors, and the further complications of it is in the form of a nephropathy. So herein the person, let me say you one thing, according to the norms of Ayurveda, the person's intestines are spoiled here because the mutra vashotas, the mutra has been collected from the intestines. And later on, it has been pumped into the basti where it has been stored for some time, and then it has been evacuated by the body in a physiological process. This is the reason the key factor for us to manage the patients is the basti. So in most of the patients with the diabetic nephropathy, I do administer the basti and I incorporate the basma basti in the patient. Basma basti is a coined term which I have did it for myself because I introduce lots of basmas into the basti dravya and push it per rectal in the form of a niruha basti, a simple dashamula niruha basti, which is processed or which is having the concentrations of Vasanta Kusumakara. 125 milligram per basti is also very effective in cases of these kinds. The rest of the thing is I use extensively lots of Potalikalpanas, and most of the times in the diabetic nephropathy, the used Potalikalpanas or the Hemagarbha and Abragarbha. Extensively, we are using Hemagarbha is a derivative of gold, and Abragarbha is a derivative of mica or biotite chiefly. The incinerate part of it has been used here in the form of basmas, which has been formulated in the form of a Potalikalpana, and that is being incorporated into the patient for the betterment. If there is a parenchymal alterations, like where the kidneys are shrunken, in those conditions, Abraga is to be mandatorily given. So Abragarbha Potali is given to them approximately around 6 to 8 grams per month, 2 grams per week, it's given. And in case the patient is having a sort of a very complicated state, then even in them, we are giving with the Hemagarbha Potali around 4 grams per month. You need to titrate the dosage accordingly and try to prescribe it to the patient against the lab reports. Because in case if you're not having an assessment criteria, then we would lose the demarking level where what dosage of medicine need to be given to the patient. Of course, the first line of treatment is a basti. The second thing is about the administration of the basmas, specifically the Abraka basma and the Swarna basma, extensively given. Vasanta Kusumakar is a drug of choice here. Whenever we speak about the diabetic management, the first line of treatment, as far as my protocol says, is the Rasayana Chikitsa. Rasayana should be the line of management which I need to give in all the patients of diabetes, even though they are clinically fit or unfit. Only there is a alteration in the blood chemistry, but they are physically fit. There is no alteration in the blood chemistry, but with slight alterations, but they are very sick. In both these extreme conditions, the chief medicine to be given is a Rasayana Chikitsa. There is a detailed enumeration of why Rasayana should be given in the patients of the Prameha or the Madhumeha. It's out of the scope for the presentation. But anyway, to just up, all the cells of the body gets shrunken up or get deteriorated. It's called as a Shiryate Anena iti Sharidam. We deteriorate day after day. And the same process happens even in a patient with diabetes, but it is more faster. Excess of the glucose levels, lack of insulin getting absorbed, and makes the cells to become further and further deteriorated very quickly. So once the cells gets deteriorated, the organic damage is very quick, wherein the patient will land up into multiple systemic complications. So to overcome these things, we need a drug which can act as a very good Rasayana. And I will say, when you read the textbooks of Rasashastra, there are nearly 600 textbooks related to Rasashastra. Out of them, most of the textbooks incorporate the whole of the index of Rasashastra as Rasayana Dravya. All the Rasaoushadhis are Rasayana. Most of them, at least 95 to 98% of the Rasaoushadhis are Rasayana in nature. So they will definitely have a good quality of the cellular functioning and also the anatomical regeneration of the tissues. The whole of the presentation is something like, if at all we are unable to compete with the Rasayanic factor of the body, then what could be the loss, and why is that it emphasizes the nephropathy complications in an individual. So this will be the chief module for today's presentation for another 20 minutes. Let me come across with what's basically happening in the body and then focus more on the kidneys in a couple of slides. The 4 features which is very commonly seen is about the polyphagia, glycosuria, polyuria, and polydipsia. So these are the 4 different conditions which we see in the patients very commonly, and everything is being related again to the urinary system here. And why this is happening, let us try to see. This is a blood vessel. Please try to cooperate with my animated pictures. I need to draw by myself, so I made a bit of animation so that you might understand it. So this is a blood vessel, what you can see. This is a blood vessel. And out of that, these are the glucose molecules, which are triangular here. And this is adipose tissue, what you can see, and this is a muscle tissue. So normally what's happening, glucose in the blood is being raised here. It is supposed to get absorbed, or it is supposed to be uptaken by the adipose tissue or the muscle breakdown. But here it is not recognized. It is not being recognized. So there is an increased amount of glucose, but it's the adipose tissue and the muscle tissue are being basically getting breakdown. Adipose breakdown and also muscle tissue breakdown, because body needs energy. Body needs energy. Even though there is more of glucose, the body demands for more and more food. That's the reason why people eat more in diabetes, polyphagia. Weight loss is there, hunger is there, polyphagia, they go on eating. The muscle and the adipose tissue are starving. The blood is overwhelmed with lots of glucose in it. This is not because the glucose doesn't want to come inside or it doesn't know to assimilate. It is not been recognized most of the time. So this is the phenomenon which is happening at a gross level. This is not pinpointing to that of the deepest biochemistry. For us to understand the clinical part of it, this much is sufficient. So you need to give some set of drugs by which the body, the components of the body will start recognizing these factors and try to uptake them. This is the reason why in all the diabetic patients, when you don't want them to land up into the complications like the nephropathy or anything, you are supposed to give them the Medhya Dravyas. You need to increase IQ level of your cell. It is doing the Pragna Parada. It is doing the Pragna Parada. You need to repair it by giving a set of drugs called as Pragna Bodhi set of drugs, or the Medhya or the Smritikara set of drugs. Let us try to see all these things in the eventual slides. So here what's happening, the glucose in the blood, which has been raised in case of glycosuria. And because of this, what's happening, the glucose is not being uptaken by the body. So instead it is coming to the kidneys. Please imagine these are the kidneys. So it is coming to the kidney, and from the kidney, as it is, it's not getting assimilated. Instead, it is coming into the bladder and it has been evacuated. That's the reason why you have the glucose in the urine. It is called as glycosuria. It is glycosuria. And the next phenomenon what you have is polyuria. So glucose molecules which has been dumped into the kidney are being osmotically active. So they try to bind with the water molecules there. So all the glucose molecules bind with the water molecules, get accumulated in the bladder and go out. So this is very commonly seen in case of type 1 diabetes as polyuria. So this is the reason why there is a lots of stress on the kidneys. Even on the physiological grounds, there is lots of stress on the kidney, and also there is lots of stress on the body parts as well. One thing keep in mind, the chief function of the mutra is kleda vidruddhi. There is excess of kleda in the body. You need to do the kleda vidruddhi. You need to remove that excess of kleda. And the chief function of the mutra is to remove the kleda, which is highly accumulated in case of diabetic patients. So try to reduce the kleda and try to increase the rasainic factor. So when you want to give to alter or you want to reduce much of the kleda, which many of the doctors do is they just dump the patient with lots of Ushna Tikshna Aushadhi. Might be they dump them with excess of Gugulu compound, some Ruksha Dravyas. They give some Haridra, they give some Gugulu, they give Shilajatu. So many drugs are being given to the patient in excess. And patient is also in such a panic mood that he has landed up into diabetes. He will start restricting much of his normal diets. Increasing all these things will make the patient to land up into the Madhumeha, which is Vata Pradhana. It is something like iatrogenic. By giving excess of Ruksha, Ushna, Tikshna, Aharas to the patient. In the case of Prameha, we are pushing him to become Vata Pradhana and making him to land up into Madhumeha, which is many times Krishna Sadhya or Asadhya. So it is what we are making that should not happen. Instead, try to titrate the patient, try to see that the drugs are being given judicially as per the requirement of the patient's condition and then use it. So what happens in polydipsia? Excess of water molecules which has been linked with that of the glucose molecules has been pushed out in the form of urine. So there is a depletion of water. There is a deficit of water in the body. That's the reason why the patient will have more thirst in diabetes. So polydipsia is one more condition. So in type 2 diabetes, the physiologist speaks about this is the pancreas wherein the insulin is being secreted. It comes out into the streams and every cell is having a receptor mechanism. It's called as insulin receptor. The insulin need to fix up to it and enter into the cell. Then it gets assimilated. But this is not happening most of the times. In pathology, it happens like the receptors are not being recognized. Even though there is an excess of insulin, the receptors are not seen, which you are able to see in the previous slide. You can see the receptors come out here. But whereas the receptors are absent in type 2 diabetes, wherein they are not being recognized, they are not being fully understood. So this pathology is chiefly compromised because of obesity, lack of exercise, hypertension, or heredity. And again, to speak about, you need to address these factors, but still, you need to give the Prajna Bodhi set of drugs because it is Prajna Parada. Knowingly, the body is doing some mistake at a cellular level. you need to manipulate it. So this receptor signaling wherein the insulin is supposed to go inside, the similar way is once the insulin enters inside, the round one is a glucose molecule. This glucose molecule also gets assimilated or get through the receptor mechanism, enters into the cell. So if this fails, even this will fail. So this mechanism actually happens in type 2 diabetes. The same mechanism happens in the kidney. The same mechanism happens in every cell of the body. So the receptor signaling is being absent. The glucose is not being absorbed. Even when insulin is not uptaken, even the glucose is not being absorbed. So there is an increased amount of glucose in the extracellular space, which is making it to have more of the deficits. So let us step now into the diabetic nephropathy. So here what's happening, with this basic outline of what we have discussed in past 5 or 10 minutes, it's a chronic insulin deficiency, which is leading to hyperglycemia. There is an increased amount of sugar levels. So this hyperglycemia will cause hypertension invariably, and hypertension will further land up into renal damage, or the hyperglycemia itself can also cause the renal damage. So this renal dysfunction or the kidney dysfunction will make it to land up into the kidney failure. So this whole thing is called as diabetic nephropathy. This is a very simple mechanism with very, very complex issue, because you're supposed to address diabetes, you're supposed to address the hypertension, the recognition factors here, because pragnaprada and dysfunction, there is where you need the Rasayana substances or else it's going to die. So you have so many factors which has been incorporated. And that's the reason why you need a drug which can act at multiple levels. So normally what I do, I have a patient suffering from cold, cough, fever, one drug for cold, one drug for fever, one drug for something else. This is not the way how Ayurveda manages it. So Ayurveda speaks about where a single drug can act at multiple levels. There are a set of drugs called as Sarva Vyadhihara drugs, which is known to be given to these patients because multiple systemic involvement is being seen. So we need to give them the drugs like that of the Abrakavasma or Swarnamakshikavasma, which is called a Sarva Vyadhihara set of drugs. So by giving the Sarva Vyadhihara drugs, it will address hypertension, it will address diabetes, it will address the parenchymal disease, it will address many of the situations related to it. Let us try to see now focusing on what's happening in the kidney. So the physiological part, what's happening in a patient of diabetes is normally in physiology, what we call it as glomerulopathy or glomerular nephritis. In any of these conditions, there is a glomerular capillary through which it's called as a afferent, where it enters inside the blood, and efferent, it's going out. There is a mesangium here, and there are pores in this. It's called as fenestration, which is 70 to 100 nanometers. And there is a small space here, and after that you have a glomerular basement membrane. And next to that, you have epithelial cells. These are the epithelial cells. And this is a Bowman's capsule. This is a glomerulus. And this is a partial epithelial cell, parietal epithelial cells. And here again, you have the fenestration, which is around 20 to 30 nanometers. The space between two cells of the epithelial cells. The space here is only 20 to 30 nanometers. And proximal convolution tubules, which is later on in the tubules. So try to imagine this is a Bowman's capsule, wherein the blood is coming here and it is passing away here from the afferent to efferent. And the particles of the blood which need to be pushed to the nephrons are being passed through these filters. There is a sieve-like mechanism called as fenestrations. Through this, it has to come out, get filtered here, again comes here, get filtered here, and then they have to come into the tubules. This is a physiological part of it. When there is loss of Rasayana effect in the body, there is lots of snigdhata in the body, there is lots of rukshata incorporated. As you can see in case of Madhumeha, where they land up into the complications of nephropathy, this elasticity is lost. The Rasayana effect is lost. They get this elastic nature is being lost, by which this fenestrations becomes quite huge enough, by which bigger sized molecules starts to leak out. Similarly, you have this space here. The space between two fenestrations also will start to leak because they move apart, they swell, they move apart, by which a bigger molecules or bigger cells of the body will start to lose away from the kidney, by which the person will land up into the renal parenchymal tissue, because much of the renal tissue itself has been scraped out and it is pushed out because of the excessive damage, which is called as a kidney failure or renal failure. So this is what the mechanism is happening. Let us try to have it in a sort of an animation. So here what's happening in stage 1 of renal failure, it's a mild injury to the glomerulus. So you need the smallest molecular leak, like you have small molecules like albumin, selective proteinurias, only albumin or selective, because they're very small molecules. So they come inside. So you can see the albumin, which is only 70K delton size. They move up because the penetration is wider now. So they move, they come here and they come into the kidney, and through the convolution, proximal convolution tubule, they come out in the urine. So these people will have albuminuria. Initially, the stage 1 of the nephropathy, they have albuminuria. So this is a condition where you need to alarm the patient and try to see that one thing is he has to get managed with his diabetic profile, where he needs to manage all the diabetic issues. He is not supposed to take chance and control the diabetes as early as possible and take the Rasayana set of drugs. The chief treatment protocol for the stage 1 nephropathy in the diabetic patient is the Mutra Kuchra Chikitsa and also the Rasayana Chikitsa. These two is very important. All the renal issues, all the conditions of the Mutra Vashotas are being enumerated by Acharya Charaka to be treated under the guidelines of Mutra Kuchra Chikitsa. Similar phenomenon, you find it in Sushruta Samhita. So based on that, I have tried to enumerate what are the drugs related to Mutra Kuchra Chikitsa with the Rasaoushadhis, and also the Rasayana set of drugs related to the Rasaoushadhis, which I'll be projecting in the eventual slides. The stage 2, it's what happening here. There is more injury where they need more Rasayana effect, or else the fenestrations are turning more and more bigger in size. So where it's happening, non-selective proteinuria, all proteins are getting pushed out. The globulin leakage also will happen. Albumin leakage also happens. So albumin and globulin, both of them are started. This triangle one and this round one, both of them have started to leak out because there is an inelasticity. The elasticity is lost. There is a damage to the cell there. It's not alone because of the rise in the glucose level. It is because of lack of Rasayana. The cells are depleted with energy. The cells are depleted with its physiological functions. You need to retrieve this, or else a person will never recover. Even though you have a diabetic complications, you happen to control the diabetic level, the glucose or the glycemic index is well under control. His renal damage is persistent. This is also seen in many patients when you are in your clinics. So you need to reverse this mechanism. You have to treat the patient with the Rasayana Chikitsa. Don't alone give the Prameha Chikitsa, controlling the glycemic index and trying to neglect the Rasayana part. In case if you don't give the Rasayana, then the patient will land up from the non-specific albuminuria to the specific proteinuria stage. This is called as a stage 2 diabetic nephropathy. So here the patient is further deteriorated. He is comfortable because he doesn't have any of the physiological stress other than bit of weakness. So try to address the situation, or else it might damage you further. As you can see here in case of stage 3, where you have a still more damage, where you get 3+ albumin moving out and proteins 2+ is going out, which is called as a non-selective proteinuria. Globulin leak along with albumin leak as injury is more. So albumin and globulin are moving in excess. They were moving to a certain extent now, they are very high now. It is called as albuminuria, it is called as a globulinuria, it's all proteinuria. All the proteins getting leaked out. So again, what you need to do here is the Rasayana Chikitsa so that it can restore these tissues. This part and this part should be restored. In case if it's not restored, then the person is going to land up into the further damage. So again, I repeat my sentence, don't give him just anti-diabetic medicines and sit. It's not the treatment protocol. You have to treat him on the grounds of the Rasayana Chikitsa. You need Mutra Kuchra Chikitsa, Prameha Chikitsa, and Rasayana Chikitsa. Or the patient will land up into stage 3 diabetic nephropathy, still more injury and non-selective proteinuria, globulin leakage is high. And here the patient will have all list of complications now. He will have hypoproteinemia, proteinemia, albuminemia, anasarca, hyperlipidemia, lipid urea, and plus other small molecule protein leakage like transferritin, iron deficiency, because once the transferritin comes to move out, then he will have iron deficiency in the body. Then the person will come stating like his hemoglobin is turning down. It's not because of a natural phenomenon of iron deficiency. There is an iron leak in the body that's making him to land up into the iron deficiency anemia. And antithrombin 3, which is thromboangiogenesis of the body, and the protein in the blood is being reduced, patient with thrombosis. Here, in case if antithrombin 3, because the blood is leaking out from this area, body thinks so there is some leakage of blood, so it starts to secrete lots of thrombus formation there, platelet and thrombus formation, and it starts to block those channels. Then here at this particular moment, when the channels are being pathologically blocked, which is called as a scroto avarodha, possibly because it's a pathological block, patient is very happy because he doesn't have proteinuria now. Patient finds like, yes, I am being treated because I had significant proteinuria by taking some medicine with the doctor. My proteinuria has been addressed well. Absolutely, there is no protein loss in my urine today. This is not a happy ending. This is a sad beginning. Just because of the reason the patient, the fenestrations are being blocked with the antithrombin 3, which is also dangerous because all these things will cause further damage to the local area. There is a clot formations there. So immunoglobulin leakage, by this you can identify one thing, the patient will have a frothy urine, protein-rich urine, thromboangiogenesis, loss of 83, hyperlipidemia, endothelial are being disturbed, and hemoconcentration is being seen. All these are being started to leak around. The treatment at this particular stage is Mutra Krishna Chikitsa, Rasayana, and Raktasrava Haradravya should be given. You need to address the situation with Raktasrava Hara, or else the patient's blood leak will be very high. In case if it's not been arrested even now, the stage 4 is still more damage, where you can see the 4+ with albumin, 4+ with protein, neutrophil loss, RBC loss, non-selective proteinuria, globulin leakage along with albumin leak as injury is more. He finds as a inflamed neutrophil loss, albuminuria, globulinuria, RBC or leaked, platelet cells stick to the injured area. You can see these platelets, they're being fenestrated and they're pushed out. Star-shaped RBC from the glomerulus. RBC cast are also, these are the typical forms of the blood cells seen in the urine. So all these things will set in, and once this sets in, oliguria sets in, no urine. Urine formation is being minimized. Then the patient's GFR is also been altered. So the GFR is also been altered. So oliguria causes urea and creatinine rise, is called as azithemia. Blood loss in the kidney is being reduced, but the hypertension sets in here. Don't be happy that the disaster to the patient has been ended here. It is further dangerous because there is something big going to happen to the patient in the form of oliguria, hypertension, and hematuria, where you have a star RBC and RBC cast, which is very commonly seen in these patients of nephropathy. So again, what you need to give in this particular stage, Mutra Krishna Chikitsa, Rasayana, Raktasravahara, and Vishagna Chikitsa to be given. Why Vishagna to be given? Because the cells which are being Vimarga Gamana, the pathological entry of the normal cells of the body, acts like Visha, and they injure the body by themselves. So this is causing again further deterioration of the tissues. You need to give them with Vishagna Chikitsa. So this is the stage 5, and wherein it's the last stage wherein the patient will land up into the renal failure. You have plus of distraction, proliferation of the epithelial tissue, and the cellular crescent. All these components of the body are also leaked out. They're coming inside. You can see the fibrin coming out, RBC cast coming out, star-shaped RBC coming out. All these cells have started to leak out through the glomerular filth. Rapid progression on the loss of the kidney function, fibrin leak, stimulates epithelial cells to proliferate, uremic complications on all organs of the body. Sarva Vyadhi Hara set of drugs to be given because it's started to affect all the systemic involvement. Renal dysfunction, acute renal failure sets in. So all these complications will happen in the patient. So the same treatment, Mutra Krichrahara, Rasayana, Raktasravahara, and Vishagna to be given. Let us try to understand it in a very simple language. The blood is entering inside into the Bowman's capsule and it is coming out. This is the blood supply. again to the kidney. Urine formation in physiology, when it is moving through these fenestrations, the urine is formed and it is coming out and it is being pushed out in the form of a physiological urine. If there is more amount of blood which is being pushed out here, there is more amount of urine which is being formed because there is excess of water which need to be thrown out in the form of urine. So this is again a physiology. It is called as increased pressure state or increased in the filtration rate of the glomerulus. But sometimes it happens like, it is just like try to understand it with a pipeline. You open the tap, you flow the water in a pipeline. There is much of the water which is going on. Just imagine there is a small hole in the pipe here by which small amount of urine is water is being leaked out here. This is how it's happening. It's entering into the Bowman's capsule and it is afferent to efferent. And much of the urine is being formed. Again, this is being connected to the blood supply to the glomerulus. So this is again the physiological part of it. But it happens in pathological part of it. The same phenomenon will happen, but there is a thrombus formation here. There is a shrinking or thickening of these vessels by which the amount of outflow is reduced. By that, what happened? There is excess of water or the blood which has been accumulated. So there is excess of urine. It is something like you open the tap and it is being pushed out. There is a small hole and water is being leaked to some extent. The same phenomenon, you are kinking the pipe here, you are folding it. Then much of the water, instead of pushing out from here, it pushes out from this hole, which is present here, like this, excess of urine. It was not like this here, but it has happened because of this kink in the pipe. So this phenomenon is seen because there is a thrombus formation. The afferent and the efferent, there is a thrombus formation. So you need to give Medo Chedahara set of drugs to remove this. So in case if this thrombus or severe, then what happens? It causes a cytokine effect, ischemic state of the nephron, because there is loss of blood supply to this. You can find the engorged vessels here, reduced blood flow, ischemic condition and atrophic of the ischemia. So these are the complications which set in case of diabetic nephropathy. So here, increased pressure causes the mesangial expansion. Cytokine and oxygen free radicals are being increased. Nephron hypertrophy causes the mesangial expansion. Nephron ischemia, atrophy, and renal failure. This is a series which happens in the patient. So at what level you have to give the treatment to the patient? Increased pressure, mesangial expansion, and cytokine. You need to treat here at the stage of cytokine. You need to give him with the Vishagdana set of drugs. Later, it has caused a hypertrophy, mesangial expansion, and nephral ischemia. Rasayana set of drugs is given. Renal failure, Mutrakritra set of drugs is given. So treatment for the diabetes mellitus should be appropriate. Treat the pressure in the means of hypertension should also be given to the patient. End phase renal disease. All these conditions like the Madhumeha, the very simple drugs given are the Chandra Prabhavati and Punarnavadi Mandura. Of course, many of the Potali Kalpanas we are using extensively like the Hemagarbha and Abragarbha. The last option could be the dialysis and the transplantation. So the patient is depleted with lots of the cellular energy. So you need to give him with the Ojo Vardhana set of drugs. The textbook speaks about the clinical administration of the Haratala, Swarna, and Panna. You need to give them with the drugs like Haratala as claimed by Rasendra Sarasangraha, first chapter 187 shloka. So everything is from the textbook. So based on this, wherever I find the Ojo Vardhaka Guna to be seen in the patient, I try to administer them with that of the Haratala, Swarna, Panna. So these are the references from the various textbooks. Rakta Pittanu, there is a Rakta Srava which we have seen in the form of hematuria in case of diabetic nephropathy. In those patients where they have the nephropathy with hematuria as a complication, like you can see the cast cells and the RBC leakage, you need to give them with that of the Gairika, Sauviranjana, Pittala, Pravala, Vaiduria, Chandrakanta, Sikatamani, and Katika. So these are the classical reference from the textbook, chapter number and shloka number. Rakta Samyukta Mutra Sravahara, Bhang is being indicated by textbook of Rasatarangini. Rakta Sravahara, Bhang, Vishatindukan, Dugdha Pashana to be given to the patient. Mutra Krichrahara becomes a routine protocol for all the cases of the diabetic complications. That is Karpura Shilajatu, Kasisa, and Bunja to be given to the patients. Basti Rogahara, Makshika Basma is being indicated by Ayurveda Prakasha. Medo Chedakaram, there are lots of thrombus formations, atherosclerotic changes, which you have seen in the previous slides. For all those patients where you are expecting a thrombus formation, you are supposed to prescribe them with the Medo Chedakaram set of drugs, like the drugs like that of the Shilajatu, Tutta, Rasanjana, Tamra, Kantaloha, Vanga, Vajra, and Vishatinduka to be given. Kapha and Pitta are the chief involvement in Prameha stage, not in Madhumeha. Then the indication could be with the Manikya, Tutta, Karpara, Shrotanjana, Saviranjana, Hingula, Tamra, Kantaloha, Jasada, Kamsya, Mukta Pishti, Gomeda. If you find it's only Kapha Pradhanaja Prameha condition or the renal damage, go with Abraka, Gairika, Haratala, Manashila, Rasanjana, Shrotanjana, Kankushta, Kampilaka, Mruddhara, Shringa, Rajata, and Tamra. Kantaloha, Vanga, Naga, Vartaloha, Manikya, Shankha, Katika, Tankana, and Vishatinduka. Kapha Vishleshana, Navasadara, Tankana, and Gunja to be given. Vata Pitta Kshayagna, where you have the Vata and Pitta, especially in the Madhumeha stage of diabetic complications. Abraka, Vimala, Tutta, Rasanjana, Rajata, Kamsya, Manikya, and Gunja to be given. Vatagna, my treatment for the Madhumeha patients landing up into the complications of the diabetes, the chief treatment protocol is Vatagna, because it's a stage of Vata. In case if you are able to control Vata, the patient will not land up into the further progression of the disease. So Harathala, Manashila, Swarna, Rajata, Kantaloha, Vanga, Naga, Kamsya, Gomeda, Rajavarta, Tankana, Vishatinduka, and Snuhi Kshira are considered as Vatagna. So these drugs could be given to the patient. These are the Pittahara set of drugs. It is considered as Karmaja Vyadhi. So Manika has been indicated by Rasendra Rasaraja Sundara and Ayurveda Prakasha. Deepana and Pachana set of drugs to be given for all these patients because it's a metabolic syndrome. For all the metabolic syndrome, the key for the treatment is the Deepana Pachana. You have the drugs for Deepana and Pachana, the index of Rasashastra, Abraka, Haratala, Swarna, Mandura, Kamsya, Manikya, Mukta, Shukti, Neela, Vaidurya, Perojaka, Godanti, Vishatinduka, Vatsanaba, Gandaka, Varatika, Agnijara, Tamra, Kantaloha, Vanga, Naga, Vartaloha, Pravala, Pushyaraga, Vajra, Gomeda, Rajavarta, Vishatinduka. Similarly, Pachana, Gandaka, Navasadara, Varatika, Hingula, Vanga, Pravala, Pushyaraga, Gomeda, Rajavarta, Vishatinduka could be given. You might say, sir, I'm really not much concerned about so much of pathogenesis. I'm not able to recognize it in the patient. Then the ready plater is being given by the Acharya in the form of the Prameha set of drugs, which can be given as Abraka, Vaikranta, Makshika, Vimala, Shilajatu, Karpura, Shilajatu, Tutta, Karpara, Hingula, Rajata, Tamra, Kantaloha, Vanga, Naga, Yashada, Mukta, Shukti, Vajra, Rajavarta, Bhang to be given to the patient. Either of these things which you find it is feasible for you and your patient can be chosen. Rasayana set of drugs, as I said, the whole index of Rasashastra is Rasayana. All drugs are Rasayana Yukta. So on that grounds, the whole drugs of Rasashastra are into this category. You can see the list and the list of references. Nothing is from my pocket. Everything is from the textbook, chapter number and shloka number. Patient loses energy. You find lethargic. So you need to give him with the Balya set of drugs. Abraka, Vaikranta, Makshika, Shilajatu, Tutta, Haratala, Swarna, Rajata, Kantaloka, Vanga, Mukta, Shukti, Pravala, Vajra, Neela, Gomeda, Vaidurya, Spatika, Godanti, Shanka, Tankana, Gunja, Balataka, Vishatinduka, Vatsanava. So these are set of drugs which are being usually chosen in any of these patients, and usually the patient responds. In case if it's quite chronic, or might be it's highly devastated with lots of energy loss, lots of parenchymal loss, there is a shrinking of the kidney, there is lots of organic alterations in the body, then yes, we have our own limitations. We are, after all, humans. We are not gods to take up any case and every case, even though it's in a stage of complications. But to the best, we can definitely do lots of favors to the patient, increase the life expectancy, give a quality of life to the patient. I know how miserable it is for the patient to land up into dialysis, how painful is the treatment and how disastrous is the patient's condition to take a repeated dialysis. I have many of the cases wherein their creatinine value was somewhere around 10, 11, 12, has shifted to 2 and 3 with a moderate management with this particular protocol, which I have tried to explain it. So this is what I try to follow up in my clinical cases and try to follow up in my center of practice. And I try to achieve, to the extent possible, the best part of what we can do through Ayurveda, and specifically with that of Rasashastra. Thank you. Thank you very much for giving me this opportunity and making me to speak few of my opinions and experiences regarding to the cases of diabetic nephropathy. Thank you.
Very prominent. Thank you very much, sir. I hope it's audible now. Some things were very, very striking the, or rather hammering the brain. The Bhasma Vasti is a coinage that you have made, and the 125 mg Vasanta Kusumagaras, and the insistence that you made based on experience on the inevitability of Rasayana component, be it the patient in a fit or unfit state, blood values normal or not. I think that's one message that needs to be conveyed down to the public also, so that people take it seriously and not just be happy and trigger happy about normal values of blood sugar. The Hema and Abhragarbha Potli that you had mentioned, and that's what I was told, that you are popularizing the Potli culture very extensively, and the specificity of 6 to 8 grams per month, and most importantly, the connection that you established with Vasti, instead of going urine directly to the kidney apparatus, the intestine connection, giving the role of Vasti, and that was simple as Dashmula available for Vasti to be done. And the Sarva Vyadhiharatva of the Abhraga and the Swarnamakshika coming to the DM, the hypertension, the parenchymal aspect. And again, we saw you insisting on the Rasayana factor. That will be a game changer, and perhaps that will supersede the expectations of public towards diabetic management from Ayurveda. And the clarity of your specific books you mentioned, the chapter and the slokas, I mean, there is nothing to be parallel about. And the most heartening factor for us would be the way you concluded the creatinine levels of 10, 11, 12 becoming 2 and 3 is nothing short of a miracle, given the support you have, the meticulous preparation quality of these Rasaoushadhis. And we cannot thank enough Dr. Mishra sir. It's beyond words what he did to you and the process to us, and God willing to the community and the society by and large. So thank you very much. I am optimistic you would oblige for more sessions from your side. Thank you very much, sir. Thank you. Next, we have Dr. Jomon Joseph Daniel. It is very interesting to realize that we have somebody, if you have noticed his classes before, that the clarity with which he takes the subject of neurology is just amazing. And why I say that is I would like to start with absolute gratitude and gratefulness to a legendary Dr. S.R. Chandra madam. She was head of department of the Government Medical College, Trivandrum, and arguably one of the best neurophysician of South India. That's our impression, that's our belief and experience. So let us start with thanking a great teacher before we zero in to a great student. Dr. Jomon Joseph Daniel, with all respect, I call him the golden arrow of the Department of Indian System of Medicine, simply because the clarity with which he has a subject is unparalleled. There's one problem I face at a personal level when I make this narration. My dear friend and brother, to most of us, he is a bit allergic to being praised. He is allergic to limelight, he is allergic to fame. He keeps it very simple. He keeps it very low profile, however big his experiences are. And that I would say that even the fact that he is perhaps the only Indian author to have found to get a chance to write a full-fledged chapter, chapter 23rd, of a book called Human Cognition as We Know Today, written by Dr. S.R. Chandra madam herself, that has found its place in the Johns Hopkins University, USA. That's not an easy achievement for anyone. And we all know that it's very rare for a modern medicine book to have an exclusive chapter from an Ayurvedic faculty. So I'm not trying to glorify our brother, as we call him, with all respect and admiration. I'll come to the point where you will be able to have the best value of his knowledge in the coming days. But that doesn't stop me from telling that he's one of those people in the public figure, in the ISM department, wherever he gets transferred. There's only time when the political parties in that panchayat come together, agree for one point, we will not let this doctor get transferred. We want to hold on him more years. That is a kind of professional acumen and the, I won't say charm, but the acceptance the public has for him. And he still likes to keep it low profile. It's also a matter of pride for us that when neurologists all over India, more than 200 of them, join every Sunday to have discussions, Ayurveda is represented by Dr. Jomon Joseph Daniel, and that's a big achievement for us and also for the modern medicine doctors to have perspectives from Ayurveda in a very authentic manner, because Dr. Jomon has a big penchant in making diagnosis in a big manner, documenting the cases very clearly, and most importantly, teaching without any element of secrecy maintained with him. Extremely transparent, extremely thorough. In all good humor, and much to his dislike, we call him Neuro Tiger. And he doesn't like it at all. That we all know that. But then, that's simply because his command on the subject of neurology is so admirable and huge. Way back in 2005, 6, 7 segment, I remember one of our big brothers, Dr. L. Mahadevan. He's such a big mentor for all of us, a legendary figure, Dr. L. Mahadevan. He asked me, Sreejit, there is a boy in the cardiology department. He asked me questions like a DM Neuro, not MD Neuro, please mind, DM Neuro. So that day we realized what merit he has in terms of neurology. And as we all know that we may use darshana, sparshana, prashna, we may use cognitions to make a diagnosis. One thing about him, the sloka called Abhyasena Prapati Drishti Karma Siddhi Prakashini applies very precisely. Again, he will be mad at me tonight when he calls me up to scold why I said all these things in public. But I just want to tell you, I'm not glorifying him. He has the capacity even to diagnose, make a diagnosis with a sense of smell. So this is why I'm telling this not to make him feel popular at all. That's not my intention. It's just to tell all of us that if the intensity of your involvement with your patient is very strong, if you're very serious with what you do, you will reach a stage which is perhaps unimaginable. And he has said to me very privately more than 5 years ago that M&D is a very major motor neuron, it's a major area of his involvement. He makes that happen. And with other many clinical conditions, some of our friends now recently know that also. Just an idea to tell you how somebody, he calls himself average, which we don't agree to, a hard worker of unparalleled sincerity and compassion at a very hyper level can achieve so much in such a young age. He's much younger to all of us. I think this is the least I should speak about him. And what really matters is that how he can be useful to you. He can be useful to you through the YouTube classes that you find in the online media. And for those youngsters or even seniors who wish to be learning things from him authentically, the best option is to have an internship at his hospital. It is Aachaara, a place near Nellambur Forest. That's a district of Malappuram, state of Kerala. And that would be the best you can make use of his knowledge. The last thing about him, again, he's not going to be happy about what I say, a thorough karma yogi. He's so detached from any sorts of praise, any sorts of acknowledgements. A thorough karma yogi and a thorough role model. We take pride in introducing to you Dr. Jomon Joseph Daniel, the golden arrow of the Department of ISM. Brother, we are all yours, but for the sake of officiality, welcome, sir. That's the way I should address you publicly. Welcome, and it's all yours. He has presentation for 2 hours, but our time constraints are like this. The last disclaimer once again, Dr. Jomon would most likely bless us with more sessions in the coming Aachaara Rasaayanam sessions, because he is somebody who can engage you for 4 hours and you won't even know the 4 hours have passed away. And that's the clarity you will have. If there's anything that you think is lacking in the presentation because of time shortage, kindly forgive us, but we will get back to you with more of his class. And yes, we are all on looking forward for his great teaching that we are so used to. Welcome. And you can start your presentation. I hope everything is fine. If there's any technical problem, we have the slide. We will help you in between. If there's any internet problem with heavy rains at your side.
Am I audible?
Yes, yes, definitely.
Okay, thank you so much, Dr. Sreejit, for those words, though I don't deserve many of them. Respected Chair, Dr. Muraleedharan sir, respected Ramadan sir, Sreeja Private Limited, for giving me an opportunity to present a paper on diabetic neuropathies on this auspicious day of your centenary celebration. And due to time concerns, I'm directly entering into the subject. It's diabetic neuropathies. Both type 1 diabetes mellitus and T2 DM patients with sufficient duration are vulnerable for diabetic neuropathy. DM is the leading cause of peripheral neuropathy, especially aged, tall, alcoholic, long duration DM patients are more prone for diabetic neuropathy. But a definite clinical syndrome simulating diabetic neuropathy is not mentioned in Ayurvedic classics. Functional aspects of peripheral nervous system, including afferent and efferent impulse conductions, is attributed to Vata. So Vata and nervous impulses, both are self-originated, propagated, subtle, reaches everywhere in body and is assessed by functions like movement, secretions, etc. And these are all basic concepts. Agni affliction at Jadarakni, Bodhakni, and Dhatutni levels lead to Ama Dhatu level. This is applicable to almost all pathologies except Agadhuja pathologies, but it's applicable to diabetes mellitus as well as the complications including diabetic neuropathy. Almost all srotases are involved. Annavaha, Udaga, Rasa, Rekta, Mamsa, Sweda, Majja, Shukra, Mutra, Purisha srotas are involved. And due to Daurbalya of Rasayanis, vitiated dosas cannot spread upwards, and hence Ubhidravas concentrate initially to Adakaya. This is very well mentioned in Shushruta Samhita, like the complications of Madhumeha are more pronounced in lower extremities. And by the word Rasayanis in the above statement, the Dhaman is transporting Rasa, Rekta, Kaba, and Pitta are to be considered. And this can be well explained by the axoplasmic flow and length-dependent dieback phenomenon of long peripheral nerves. You see, why the lower limbs are more affected or very initially affected? Why? Because the longer the nerves, the grievous is the pathology. Why? Because in the peripheral nerves, the nerve gets nutrition through a phenomenon known as axoplasmic flow, and it is much more earlier affected in the case of longer nerves than shorter nerves. And since our lower limb is having longer nerves, our lower extremities are going to be first affected by the complications of diabetic neuropathies in the very initial phase itself. And because of this length-dependent dieback phenomenon, it is the peripheral axons and axonites, they are going to be affected first because of these issues. And it is because of that we get a distribution of sensory impairment just like this. It is known as glove-stalking appearance. The lower extremities are affected first. And when the numbness or burning sensation or paresthesia, whatever be the sensory motor phenomenon or combination of sensory motor phenomena the patient suffer from, once the lower limb get affected up to the knee aspect, then upper limb also get start involving. This is known as glove-stalking appearance. So Avarana of Vada by the vitiated doshas and the 10 doshas that already mentioned are responsible for the various presentation of diabetic neuropathy. Diabetic neuropathy is not a single presentation. In the OPDs, we get many varied presentations of diabetic neuropathies: small fiber neuropathy, large fiber neuropathy, mixed neuropathy, amyotrophy, monomelic, generalized. So many presentations are there that we come into discussion in our next slides. In a population cohort study of diabetes mellitus patient, 2/3 have objective evidence of some types of neuropathy. So that is the grievousness of or the burden of this particular complication, diabetic neuropathy. This point is very important. Perfect functioning of recta, medas, and ojas are mandatory for the proper functioning of peripheral nerve system. It's very important. Pradhana vyadhi of diabetic neuropathy is madhumeha only. That means without treating or controlling the pradhana vyadhi, it is tough to treat a diabetic neuropathy complication. Doshas are meda, mamsa, kleda, shukra, shonida, vasa, majja, lasiga, rasa, and ojas. All of them are involved and lead to varied presentations starting from neuropathy up to erectile dysfunction or premature ejaculation or retrograde ejaculation or diabetic affected bladder functions, etc. The permutation combination of 3 doshas and 10 doshas lead to various manifestations of the neuropathy. Now coming to the classification of diabetic neuropathies, it can be symmetrical polyneuropathies, asymmetrical neuropathies, and combinations. What are the symmetrical polyneuropathies? Distal sensory or sensory motor polyneuropathy, small fiber neuropathy, large fiber neuropathy, and autonomic neuropathy. By the term small fiber neuropathy, it means small fiber are less myelinated or least myelinated peripheral neurons in which it presents as axonopathies. The main presentations will be pain, burning sensation, pricking pain, various type of pains. Whereas large fiber neuropathy means they are more myelinated fibers. The pathology will be demyelination, and the presenting complaints will be numbness, abnormal joints, the pain will not be that much. The loss of sensation and motor manifestation will be more. And this, because of this numbness and proprioceptive issues, the patient will have deformed joints known as Charcot's joints or Charcot's neuropathic joints. And these type of patients are more prone for diabetic foot ulcers. So when the patient comes to our clinic in the initial phase, by assessing the clinical features, if the patient is present with the sensory phenomena like pain, burning sensation, etc., more involved, then we can understand this is small fiber neuropathy. Then we have to treat accordingly. That we'll discuss in the following slides. If the patient is having less pain, but more predominantly numbness, loss of sensation, and muscle weakness, then it's a large fiber neuropathy. They will also have proximal muscle wasting or proximal muscle limb girdle muscle weakness will be there, and they will have more chances of foot ulcers. So that we have to take into consideration even in the very initial phase of the pathology itself. And autonomic neuropathy affects almost 3 major systems like cardiovascular system, bladder function, genitourinary system, and GI tract. That will come into later. Asymmetrical neuropathies can be, the previous slide we discussed about the symmetrical neuropathies in which both sides of the body will be equally or some more or less equally affected. But in the case of asymmetrical neuropathies, individual nerves situated in elsewhere in the body can be affected, like cranial neuropathies. It can be single or multiple. For example, seventh cranial palsy, or that is the most common type of individual cranial neuropathy we see in our OPD. That is, patient comes with the element type of facial palsies. Then truncal neuropathy, that is thoracic radiculopathy. We are all aware of lumbosacral or cervical radiculopathies, but there is a condition on a truncal neuropathy in which the patient will be present with the thoracic pain and abdominal pain alone. That will be mistaken for angina or some type of abdominal pathologies, but actually it is truncal neuropathy. Will have radiating pain, aching pain, various type of pains in the trunk of the body. Then limb mononeuropathy can be most of them are compressive neuropathies. Upper limb, it's ulnar neuropathy. Lower limb is peroneal neuropathy, most commonly leading to foot drop or claw hand, etc. That each of it will deal in detail in the coming slides. Lumbosacral radiculoplexiopathy, it's just like a sciatica, or it can be present as a plexopathy also. Then entrapment neuropathy is most common as carpal tunnel syndrome in the upper limb and tarsal tunnel syndrome in the lower limb. And compressive neuropathy, as we already explained, in the ulnar neuropathy in the upper limb, and peroneal palsy leading to foot drop in the lower limb. Then combination can also happen. Polyradicular neuropathies, diabetic neuropathic cachexia, symmetrical polyneuropathies can also happen. That will come in later. Then these are the classification. Now coming to the real picture in our clinics, we are able to diagnose all these things in the clinic itself, or in the clinical room itself, within an examination of 5 or 6 or 7 minutes at the maximum. So what is the clinical examinations? Increased vibration detection threshold value is the best clinical examination finding. That is the most useful clinical examination is to test the lower limbs as well as upper limb of the patient with a vibrating tuning fork of 128 Hertz. And normally the patient should, depending upon the age, he or she should detect a vibration of 128 Hertz for more than 20 seconds or 25 seconds in a younger age. If it is decreased, we can say that it's a demyelinating pattern or myelinopathies or peripheral neuropathies there, and monofilament sensory testing. So these are the gadgets we use to test a tuning fork. Is very much needed to detect a neuropathy predominantly of myelinopathies, and a cold and warm test, and a pinprick test with the help of a toothpick. And this is a monofilament apparatus. Monofilament is calibrated. Actually, this pen is with the 10 grams. With the help of this monofilament, you can test the pressure points, especially over the sole of the foot. That helps to detect the chances of upcoming diabetic foot ulcers very early itself. So these are the gadgets which help in our OPD with the simple, very simple, less time consuming examinations in which we are able to detect a diabetic peripheral neuropathy, either of axonopathy or demyelinating pathology in the very early phase itself. Then once we are in a doubtful stage, we can go for lab investigation like nerve conduction study or EMG, etc. So cotton wool can help us in light touch perception, then 2-point discrimination, And this is a vibration. Vibration, first you have to check the distalmost area, distal toe, the tip of the great toe. This will help. If the patient is able to sense the vibration for that speculated time for more than 20 seconds or so, then there is no need of any further examination. But if the patient fails to detect the vibration for the speculated time in the tip of the big toe, then we have to progress to the next bony prominence, that is usually the medial malleolus, bony prominence. Never check never check a vibration sensation over a muscle belly or muscle bulk. Always check in the bony prominence. Then only we'll get the correct idea. Then we go for proprioception, position sense of each major joints. Then types and prognosis of diabetic peripheral neuropathies. Distal symmetrical mixed polyneuropathy. The patient will have both sensory as well as motor manifestations like weakness, slipping off of chappals unknowingly, then burning paresthesia, pins and needles, etc. It is having the worst prognosis. This is the most common type, but this is having the worst prognosis. Proximal asymmetrical plexopathy, diabetic amyotrophy, that as I already said earlier, the patient will have weakness or wasting of the proximal muscles. But if detected early, it is a little bit easily treatable condition. Focal and multifocal neuropathies, purely small fiber neuropathy, that is axonopathy, purely large fiber neuropathy, that's myelinopathies, purely autonomous neuropathy. Purely autonomous neuropathy with cardiac manifestations or GI manifestations or genitourinary manifestations are a little bit tough to manage. Prognosis is not that good because autonomic neuropathies are, majority of the autonomic neuropathies are small fiber neuropathies, axonopathies. It's tough to treat actually. And CIDP, chronic inflammatory demyelinating polyneuropathy type of presentation, in which the demyelination, recurrent chronic demyelination are the main pathology. 400 milligram per deciliter. Hypoglycemia-induced neuropathies are also there, and insulin-induced neuropathies. Insulin-induced neuropathies are usually painful neuropathies. Usually, the patient comes to an OPD with the presentation of severe pain soon after the starting of insulin therapy. So they are known as insulin-induced neuropathy. That can also be treated well with add-on therapy as per Ayurvedic designs. Then investigations, of course, the basic investigation will be complete serum chemistries, fasting blood sugar, glycosylated hemoglobin, glucose tolerance test. Then there's a specific test for detecting the Pradhana Vyadhi. And next is the concern specifically to the neurological and muscle pattern. That's the EMG and condition study. Skin biopsies can help to detect what type of neuropathy the patient is suffering from, like the patient is having any microangiopathy or axonopathy or something like that, and vitamin B12 and thyroid function testing. The diagnosis of diabetic neuropathy is based on clinical symptoms, objective neurological signs, and electrodiagnostic confirmation that we already discussed about. Distal symmetrical polyneuropathy, most common type of diabetic neuropathy, distal symmetrical polyneuropathy that we already discussed, in which the patient presents with the both sensory as well as motor manifestations. Sensory manifestations are more predominant than motor manifestations. Sensory manifestations include loss of sensation, positive sensory phenomena like burning sensation, paresthesia, pins and needles, or negative sensory phenomena like anesthesia or hypoesthesia. And motor manifestations, usually wasting and weakness. Length-dependent dimebactosis, glove-stocking appearance can be detected. Large fiber neuropathy are usually painless paresthesia at toes and foot. Impairment of vibration and joint position sense are the more common type of presentation. Diminished muscle stretch reflexes. In advanced cases, significant ataxia may develop because the patient will not be able to detect the joint position because of the demyelinating pathology. Okay, small fiber pathology is the axonopathy, and the large fiber neuropathy, it is the demyelinating pathology, in which the pitta recta medo involvement is more in the case of large fiber neuropathy because it's demyelination, and in the case of axonopathy, vada and vada pitta is the more predominantly involved culprit. So Brahmana Rasayana and Medhi Rasayana is important. Direct armature Schwanz's due to inflammation of vascular metabolic causes in large fiber neuropathy, pitta and vada pitta shamana is needed here. Small fiber neuropathy, vada shamana is needed. So coming to the small fiber manifestation of small fiber neuropathy, it can be burning sensation, it can be ice cold sensation, all are sensory, positive sensory phenomena. So how will you address it? Using common sense and logic, burning paresthesia, pitta and vata, pitta predominant, pins and needles, lancinating pain. There are various types of pains. The vata is the main culprit. Hyposthesia or numbness, kapha and vata kapha, the main culprit. Anesthesia is the total loss of neurons at that area. So total damage is a vata. Then hyperpathia, hyperalgesia, hyperesthesia, and allodynia are various type of pain presentations, and vata is the main culprit. These all are the sensory phenomena and interpretations. Whereas coming to the motor manifestation, wasting is the most. Wasting means thinning of muscles along with weakness. This is the most common type of motor presentation. And how we manage it or take it to consideration is, if it is acutely progressing, it is vata pitta. Subacute or chronic progression is vata kapha, and static, once the damage of the nerves have been complete, it is vadiga. Then how to come into management? Treat and control the metabolic anomaly initially. That is the treat and control the pradhana vyadhi. And coming to the ubhidra vyadhi, that is diabetic neuropathy, this is the nutshell. If it is axonopathy, it's better off to vadahara treatment. If it is demyelinating pathology or large fiber pathology, pittahara and vata pittahara treatment is needed. Taller the patient, worse is the outcome. Suppose we have two patients with similar presentations of diabetic peripheral neuropathy. One patient is shorter and the other is taller. The taller patient will have comparatively bad prognosis because his nerves are longer. As the longer the nerves, it is the damage will be more. Since there is microangiopathy, better avoid excessive Svedana procedures, Tikshna Ushna Aushadha Ahara Viharas. This is very important. You are not supposed to do, though the presentation is vadiga, in the case of diabetic neuropathy, like numbness, or various type of pains or wasting or weakness, you are not supposed to go for so much Svedana procedures, sudation therapies. That is why Aachaarya also mentioned that Prameha Roga or Rogi or with the Madhumeka stage are Sveda Anarha. So, because of the intensive Svedana you are doing, can go, the microangiopathy can worsen. And advise best food care. So what is the treatment principle? Good glycemic control. Anilomanam must be maintained always. Sahajara, some options, drug options are Sahajara Beladika Shayam, Sahajara Bela Guluji Devadaru Nagara, Vari Bela Amradadika Shayam, more apt for lower lip presentation. And Gulujik Shirabagam with the Shirabala Avarti is very effective. It helps to maintain myelination process. It is also helpful in, it acts as a rasayana. Basically, this is a rasayana combination. Gulujik Shirabagam with the Shirabala Avarti is found to be very effective in managing various type of sensory as well as motor presentations of peripheral neuropathy. Then Sahajaradi Kashayam with the Sahajaradi Avarti, Rasta Saptanga Kashayam. Depending upon the presentation, depending upon the dosha involvement and localization, you can go for any of this combination like Prasaranyadi, Bhadradarvadi, Ashtavargam, Sahajaradi. And if the numbness is more predominant, you can go for Shundi Beladi Kashayam. But remember, always use most suitable Sneha preparations, either Rasa or Grida or Thaila, accordingly as a Praksheba. And Chandraprabha Badi have a significant role. And for Thailam selection, you can go for Kshirabala Thailam or Madhyashteri Thailam mentioned in Vada Shonada, because in many of the conditions can be sensory presentation like burning paresthesia and all. Gugladutangradam, Mahatagradam, and Dhanandrangradam are all options. And external Kriyakarmas, Udvartanam, Dhanyamaladaram, Takradara have commendable effect on managing diabetic peripheral neuropathy. Remember that too much snehana like abhyanga, various type of kaisega or pirinjadaval or various type of oil usage externally is not having that much ubashaya in the case of diabetic peripheral neuropathy. Udvartanam, Dhanyamaladaram, especially Takradara is found to be very effective. And in some cases, when the glycemic control is under control, and the patient is having more recta pitta predominant conditions, like presentation like burning paresthesia or various type of allodynia, etc. Chelugavachan is also found to be effective for minimizing the sufferings of the patient. Now coming to diabetic polyradiculoneuropathy, involve proximal segments of the peripheral nervous system. Multiple lumbosacral, thoracic, cervical, myeltomes may be affected. So in the case of cervical and in the case of lumbar or lumbosacral root issues, we may misdiagnose the case as IVDP or sciatica. Actually, we have to check whether the patient is having uncontrolled diabetes. There can be a complication of diabetic neuropathy, diabetic mellitus, leading to diabetic polyradicular neuropathy. EMG shows low-grade active denervation changes in paraspinal muscles also, so that the muscle will be flabby. The patient can have scoliosis depending upon the weakness of the paraspinal muscles. Other is Aachaara Rasaayanam, Chandraprabha Guliga, Vaishwanara Churnam, and coming finally to Ashwagandha Rasam, because all these conditions should be initially treated based on dosha predominance, a maiden assessment based on the clinical presentation, and finally it should end in a rasayana. A proper rasayana should be selected. Whatever may be the type of neuropathy the patient is suffering or presenting with, our final treatment conclusion should be on a suitable rasayana. And especially in the case of myopathies, neuromyopathies and plexopathies, ashwagandha is a good choice. Regular physiotherapy, udvartanam, dhanyamladhara, and local shastika leba. Why I included local shastika? Because in this type of plexopathy or radicular neuropathies, there will be muscle wasting associated rather than the typical pain. Muscle wasting will also be associated. So we have to incorporate local Brahmana treatment too. Then impaired glucose tolerance neuropathy, peripheral neuropathy before the onset of clinically diagnosable DM. This is a very challenging situation we see in our OPDs. The patient will not be having a significant hyperglycemic level, but the patient will be having peripheral neuropathy. So we'll be confused. We'll not be able to, patient will be comparatively of middle age or early 40s or 50s, and patient will be present with the typical presentations of neuropathy, but we'll not be able to detect any detectable cause for this neuropathy. So always remember that here we have to do a oral glucose tolerance test, GTT, because it's a pre-diabetic stage. Even that is the what we say a trick here. Like we always expect that the patient with the diabetic peripheral neuropathy will definitely have prolonged history of uncontrolled diabetes, but it's not like that. In some cases, we get diabetic neuropathy even in the pre-diabetic stage or very early stage of diabetes mellitus, whether it is type 1 or type 2. So always remember to do an oral glucose tolerance test. Electrophysiology test shows intraepidermal nerve fiber density reduction. Predominantly, they are all predominantly small fiber neuropathy. So impaired glucose tolerance neuropathies are almost all of them are small fiber neuropathy. That means the patient will be presenting with the pain, various type of pains and burning sensation, positive sensory phenomena, rather than demyelination, paresthesia, numbness, or muscle wasting. They will be present with the pain presentations. So patient with the undiagnosed painful peripheral neuropathy. So this is the conclusion. Patient with the undiagnosed painful peripheral neuropathy should undergo oral glucose tolerance test. So what is the advice for them? Regular exercise, diet with low glycemic index. Amrutotharam Kashayam is the best choice here. And the wonder drug here is Tinospora cordifolia alone. So Amrutotharam Kashayam is the best choice in this condition. Nisha Amalaki can be started very early itself, and Ksheerabala Avarti. This is the wonder combination, so that the patient will be will not be progressing to a full-fledged diabetes patient, and we are able to control the issues of neuropathy in the very early stage itself. This is a very important clue clinically. We are detecting so many cases. And once we start treating a diabetes patient very intensely, aggressively, that treatment itself can lead to neuropathy presentation. We are getting so many cases who got recently started with modern medicine treatment or insulin comes to our OPD. Because they says that the modern literature says that insulin-induced neuropathy can last up to 1 year or 1.5 years. Then later it will be vanishes. But the patients used to come to us because they says that my glycemic level is under control by the modern medicine treatment, but I'm suffering like hell with the complications of neuropathy. Can you manage that? So in such situation, we have to take the patient for add-on treatment. Acute painful neuropathy precipitated by good glycemic control by treatment. Distal lower extremities burning pain and paresthesia shortly after attaining good glycemic control is the presentation. Pain persists for few weeks to months to years, indicates active axonal regeneration, which generates spontaneous nerve impulses. So this is the basic pathology there. It is not a worsening pathology. Actually, it is a good pathology. Like the axons are getting regeneration, and it is the high firing from the aberrant firing from the regenerating axons that create the intense pain for the patient. So what we have to do is our management should be aimed to fasten or speed up or accelerate the nerve regeneration. We have potential drugs with a good amount of nerve growth factor NGF that can promote nerve regeneration once you start regenerating. Guluji or Belak Shirapagam with the Shirabala Avarti. Guluji Shirabaga is my favorite choice in such a condition. Sudarshanam Churnam, if given precisely, is very useful to control the pain in that situation. Kadagadradi Kashayan is Shamalagi is of good choice. And one or two combinations with the good amount of nerve growth factor. So once you control the pain, burning sensation with the medicines, then your aim is to rejuvenate or fastens or accelerate the nerve regeneration through our drugs having Rasayana property. One of our drug with the Rasayana property as well as plenty of NGF is Mahamasha Thailam, and other is Ashwagandha that can be selected here. Assurance is very essential. The patient will be emotionally very unstable. So assurance is very essential. Not only in this case, while treating every case of peripheral neuropathies, patient will be suffering from burning pain 24/7, disturbed sleep, Russell syndrome. The patient will be having muscle wasting, slipping off of chapels, can't stay, climb up or climb down stairs. So the daily activities of the patient will be so much affected. So the patient will be having so much depression. So emotional support and assurance is very essential. Pain resolution occurs as the axonal sprout reaches the sensory nerve stimulus. So once the axon sprouts very fastly with the help of our management, reaches the sensory nerve endings, then pain start resolving or subsiding. Then another condition is diabetic neuropathy, cachexia, acute painful neuropathy associated with a severe weight loss, depression, insomnia, impotence in men. And the weight loss is very pronounced there. The patient will lose kilos and kilos of weight within a course of within few weeks or months. This is one of our patient, very young patient, 15-year-old boy came to our OPD a couple of months back in September, I think. The patient was presenting with the unexplainable severe muscle wasting, around about 18 to 19 kg within 3 months. So we send the patient for a glycemic test, and the random blood sugar at that level was 440. So that is why I said acute painful neuropathy with a severe weight loss. More common among men with a poor glycemic control. Improved glucose level and weight gain often result in good recovery. What can they to manage the painful situation? You can go for Dhanya Muladhara. Here also, please don't go for Abhyanga or Ushma Sveda or Pirishil or Kaya Sega. Nothing is needed actually. Dhanya Muladhara is the best choice, and Dashamula Sruddha Kshiradhara can also be given to manage the painful situation. And to manage the insomnia condition, you can go for, that is only selectively needed, Kshirabala or Madhushtira Thailam Shirodhara is found to be effective in some cases. Guluji Kshirabhagam and Gugulu preparations. Show that the Gugulu preparations are found to be very effective. Manjishtadi Kashayam, you can either give us Kashayam or Kshirabhaga, Ashwagandha in milk, and Dhanvantari Grudam are found to be very effective in managing these cachexia situations. Coming to another major complication of diabetic neuropathy is diabetic foot ulcers. Sensory loss makes the diabetic mellitus patients susceptible to repetitive unnoticed injuries that lead to foot ulcers and at distal joint distress, that charcot joints. Vascular insufficiency, secondary infection have cumulative effects, can lead to limb amputation itself. So Mahamanjishtadi Kashayam, Madhusnihi as a Rasayanam, it's not the combination, but single drug Rasayanam, Annabedi Sinduram, the Sabra Gugulu are found to be effective in this condition. And Karanjapatra Kashay for Dara and wound cleaning is found to be effective. Another very useful combination mentioned in Ashtanga Hridaya, Kushta Pragarana, Chilsa Pragarana, which is very effective in management of diabetic neuropathy, especially sensory predominant neuropathy, as well as in diabetic foot ulcer is Bodhimba Nimba Tripala, Padmagadi Churna with the Madhu and Gridam is found to be effective. The Gridam you can go for Tikta Gridam or even Dhanandram Gridam here. So do check your feet every day. These are do's and don'ts advices we usually give for a diabetic foot ulcer patient. Check your feet every day for cuts, cracks, bruises, blisters, sores, infections, and always use a mirror to check the bottom of the foot at the end of the day to check whether there's any bruises or marks. We generally says that take care of your foot just like you take care of your face and wash and dry your feet every day, especially between the toes. Pada abhyanka every day on heels and soles. Nalpamaradi, Pindadailo, etc. can be used, but wipe off the excess. Because remnants of moisture or oil in between the toes can itself lead to alasam-like or ulcers, then can progress to foot ulcers. Change your socks every day, trim your nails straight across, clean a cut or scratch with mild soap and water and cover with a dry dressing, and always wear food, especially for ladies, shoes and chappals with less than 5 centimeter heels. Buy shoes in the late afternoon. Don't buy shoes in the morning, because in the late afternoon there will be pedal edema. So if you buy a footwear in the morning, that will be very tight and lead to abrasions and ulcers in the evening. So better select chappals in the afternoon. Avoid extreme cold and heat, including sun. See a foot care specialist if you need an advice. Do not cut your corns or calluses by yourself. Do not treat your ulcers or ingrowing nails with razors or scissors. And don't use over-count medications to treat corns and wounds. So these are the don'ts. And never smoke or alcohol, because smoking and alcohol can increase the chance of or worsen the pathophysiology of diabetic neuropathy, can again lead to complications. So this is not neuropathic joints or Charcot joints. Patients with diabetic neuropathy with these type of joints are very, very prone to diabetic foot ulcers. This is grade 4 ulcer. One of our patient we treated a couple of years back. So these are the step-by-step documentation pictures, and finally the wound get completely healed. So what is the combination given here for this particular patient? Manjishtadi Kashayam, Rasasinduram capsule, and Nabedi Sinduram. Because always remember that you have to add an iron supplement whenever you treat a wound, a chronic wound. Even though the HB will be within normal limit, you have to supply Nabedi Sinduram or some iron supplements to fasten, just like a protein supplement. Two conditions you have to ensure is proper iron supplement and extra protein supplement to fasten the wound healing phenomenon. Tripala Karanja Bija Kashaya Kshalani is found to be effective. Jatyadigaram application, this Vrana Shodhana Robanam and Vrana Vasti with the Parantyadi Thailam is found to be very effective to manage a diabetic foot ulcer and protein-rich diet. Now coming to diabetic autonomic neuropathy, I already mentioned that 3 systems which are majorly affected by diabetic autonomic neuropathy are cardiovascular autonomic dysfunction, gastrointestinal, and genitourinary. What are the hallmarks of cardiovascular autonomic dysfunction? Orthostatic hypotension. The patient will be having orthostatic hypertension. Well, how will you diagnose clinically? Check the BP of the patient in sitting and standing postures. If there is a difference of 20 millimeter of mercury, either in systolic or diastolic BP of the patient in these 2 postures, postural hypertension is diagnosed. Resting tachycardia, heart rate unresponsive to respiratory rate. These are the cardinal features of cardiovascular autonomic dysfunction. Increased incidence of silent MI is reported among diabetic autonomic neuropathy patients. So it is very important to diagnose cardiovascular autonomic dysfunction in patients very early to avoid these complications. Gastrointestinal autonomic dysfunction, GI motility abnormalities, and fecal incontinence are one of the most important complications of GI autonomic dysfunction caused by diabetes mellitus. Delayed gastric emptying leads to nausea, postprandial abdominal bloating. Diabetic diarrhea due to small intestine involvement typically occurs at night. Colonic atony leads to constipation. So there will be intermittent diarrhea, especially at night, and constipation. Bacterial overgrowth causes diarrhea as well as bloating. So how will you treat it? Just like Gulma Grahani Chikitsa may be incorporated here. Dadimastaka Churna is a brilliant choice. Sukumaran Kashayam with Villuadi Guliga is found to be effective in treating this colonic atony as well as the small intestine involvement diarrhea, especially at night. Then Hingua Jadi Churna for abdominal bloating, Villuadi Guliga and Krimikna Vadiga can be used. But basically, these are all just templates, examples of some yogas. You can select as much as you can based on the Gulma and Grahani Chikitsa Prakarana. Now coming to genitourinary autonomic dysfunction, this is very common in our OPDs. Bladder atony leads to prolonged intervals between voiding. So bladder atony is there. The normal tonicity of the bladder will be gone. So though there will be polyuria, the large volume urine output will be there, but the gap between or the interval between 2 voiding phases will be prolonged. And this can lead to gradual increase of urinary retention and finally results in overflow incontinence. So this is condition known as diabetic bladder dysfunction or DBD or cystopathy is very common in our neuro clinic. Decreased bladder sensation, increased bladder capacity and impaired bladder emptying with resultant elevated post-voidal residual urine is the cardinal feature, and erectile dysfunction are also seen here. So patient should be encouraged to void every 3 hourly to prevent urinary retention and resultant renal damage. So what is the complication of this atonic bladder is that the patient will have large bladder. So there will be persistent urinary retention and resulting renal damage. So patient should be educated and encouraged to void every 3 hourly. Viradharadi Kashayam with Dhanundram Avarti can be given. Vastyamendaka Gridam, Dhanundram 101, Chandraprabha Guliga found to be effective. And Dhanundram Thailam, Soprapipi Piju, as well as Dhanundram Thailam intravesical Utravasti is very effective to manage this situation. And we used to give Dhanundram Thailam intravesical Utravasti in these type of DBD patients. And I'll demonstrate one of the patient procedure we did in our IP. We are doing many such Utravastis. And while doing the planning or the treatment protocol of Utravasti, what we target is the detrusor muscle, the muscle at the bladder of bladder muscle, detrusor muscle, and sphincter, external sphincter, because there is a condition once the atonic bladder is attained, there is a condition of detrusor external sphincter dyssynergia. So this dyssynergy itself lead to bladder complications. And we also target autonomic nerves, urothelium. We all know that is stratified. Sorry, transitional epithelium is there inside the bladder and urethra. All of these are the target organs while doing an Utravasti. I will show you. It's a very easy procedure. We all can perform. First, we clean the area. To avoid discomfort, you can go for a local anesthetics like lignocaine, 2%. You can either use a nail cath or a rubber catheter for performing Utravasti. Now here I am using a nail cath. We can give round about 50 to 70 or 80 ml of Vastidravya like this. And in some cases with erectile dysfunction or with extensive dyssynergia, we are also using Vastyameda Gruda for Utravasti. So what is that? Polyuria can lead to significant bladder atrophy, hypertrophy, hyperglycemia, oxidative stress in the bladder. So polyuria always lead to significant bladder hypertrophy and retention, and hyperglycemia can lead to oxidative stress in bladder. So both of these conditions, significant bladder hypertrophy and oxidative bladder stress, can in long run lead to bladder function failure leading to DBD. And what the answer to the situation is Rasayana. And after performing an Utravasti, always ensure that the urine is initially voided out and later the Vasti Dravi also is voided out. Then only our procedure is complete. You can also measure the voiding material. So Rasayana with the blood sugar level lowering of the Vasti Jeshu Girijam Shilajadu is a apt Rasayana drug that can be given here. So about 60% of uncontrolled diabetes DM patients or men will have impotence. Autonomic dysfunction can cause both erectile dysfunction and retrograde ejaculation. That can be well managed with the Utravasti and following Rasayana treatment, especially Shiva Guliga or Shilajadu. Then coming to pseudomotor abnormalities, like because of the autonomic dysfunction, the pseudomotor abnormality like vasculature and sudation or sweating will be affected. Distal anhidrosis, that is means there will be absence of sweating in the limb ends. Below elbow, below knee, there will not be any sweating. Distal anhidrosis with the compensatory facial and truncal sweating. But in compensation to that, there will be excessive sweating in the face and trunk. And heat intolerance. This is a typical presentation of pseudomotor abnormalities. So we may miss such situations. And another type of, or another category of this patient with the pseudomotor abnormalities will present like profuse sweating over face and forehead immediately following food intake. So patient will say that I'm having profuse sweating from face and chest area soon after food intake. Actually, this is a neuropathy, pseudomotor abnormalities due to diabetic complications. So Guluchadi Kashayam with the Shariba, excess Shariba, or Drakshadi Kashayam with extra Shariba is a good choice here. Guluji Kshirapagam, as already mentioned, Kshira Guluji preparations and Sudarshanam Churnam are found to be effective. These are all just examples or templates. You can select your own drugs based on the principles. Then is lumbosacral radiculoplexopathy, diabetic amyotrophy, majorly present with the muscle wasting and weakness proximal. Asymmetrical weakness and wasting of pelvic femoral muscle, general weight loss. Upper limb severe pain unilateral severe pain in lower back and hip and anterior thigh, diminished muscle stress reflexes, and EMG is a diagnosed tool. In this condition, we have to trust on electromyogram for a proper diagnosis. Guguluttam Kashayam. Guguluttam Kashayam with the Nimamrada Erandam and Shodhida Gugulu is a drug of choice. Adari Sajara Kashayam with the Sajara Avarti. Vasanta Samagra Rasam is found to be very effective in managing Shilajadu Rasayana, Shiva Guliga. Then Mashadma Uttadailam for prolonged period. Vasanta Samagra Rasa, Shilajadu Rasayana, Mahamasha Thaila can be used, selected as a Rasayana drug and can be given for a prolonged period to prevent further complications. And Dhanvantharam Gridam is a good choice. Uddvartanam, Churnapanda Svedam, and Shashtikalabam found to be effective. Always do not go for excessive Sedana procedures. You have to bear it in mind. Limb mononeuropathy. These are two basic mechanisms: nerve infraction and nerve entrapment. Nerve infarction means supply to the nerve has been affected by vasa nervosum blockage, and nerve entrapment, for example, carpal tunnel syndrome. Infarction leads to abrupt onset of pain, followed by weakness and atrophy. Recovery tends to be very slow. Entrapment neuropathies are common, and the commonest is CTS. Entrapment neuropathy, we all know, it's a boat-shaped depression in the thenar eminence. It's one of the presentation, third stage presentation. So we can go diagnosis clinically only, but for confirmation, you can go for nerve conduction study, reduced amplitude, partial conduction block, absent response, complete conduction block. Management of this entrapment neuropathy, look for hypothyroidism, fracture malunion, scaphoid bond, acromegaly or spaciocular lesion, that's of DDs. Then Kababrada was the main culprit here. Phase 1 is there. There are three phases in the clinical presentation, phase 1, 2, and 3. Phase 1 will be predominantly numbness. Kabahara treatment should be opted here. Phase 2 is weakness and pain predominant. Vada Pitta Shamanam needed here. And phase 3 is the wasting phenomenon. It's bad prognosis with Vada predominance. Vadahara treatment, Brahmana treatment is opted here. Some drug options in phase 1, which is a Kabahara treatment is needed here. Varanadi Kashayam, Ashtavargam, Rasavanadi, Rasna Shigruvadi, Rasna Shuntiadi, Patya. Some examples. Google Panchola Churna with honey for prolonged period internally is found to be effective in this situation. Shaddarnam tablet, Chandraprabha Gulika. Google Tuktan Kashayam with the Google Panchavala Churna is found to be effective. Externally, Kartavator Marvata local labana, Kotajukadi Churnam, Chininayagam in egg white or Acnirma. Some of our colleagues goes for Acnirma, but I never practiced Acnirma in this situation. Phase 2 is pain predominant and weakness situation. Rasnandadi Kashayam, Vidairadi Kashayam, Chirabella, Prasarani, Kshira Kashaya, Rekta Moksha is found to be effective in this phase. Rekta Moksha, this is the anatomical picture, localization of median nerve. We usually go for rectal moksha in this point. Yeah, that red dot area. We can rectal moksha is extensively practiced because many of the patients come to our OPD in the phase 2 only. Phase 1, many of them may not come. But once the pain starts and their daily activities get hampered, patient used to come to our OPD, and we get a lot of patients in the phase. And we are extensively practicing rectal moksha or modified shringa in this area to manage the second phase. I'll quickly show a video demonstrating rectal moksha in our OP in second phase of CTS. But always bear in mind that the glycemic, if the patient is diabetic, uncontrolled diabetic, always bring the diabetes under control before this procedure for avoiding secondary infections. This is the point we usually prick just above the carpal tunnel. And we go for modified shrinka. Around about 5 to 10 ml of blood is removed in one sitting and is banned. Murivanna is applied and bandaged. Phase 3 is the Vada predominant situation with extensive thenar muscle wasting, and it's a bad stage, bad prognosis. But if it's a pratyakya, but we can treat if the patient is sticking on to us. Maharasnadi Kashayam Yogarajam, Prasanadi Kshirapagam, Maharaja Prasarani Tailam Savyam, Sahajradi Tailam Savyam, Sahaja Mamsarasa, Mahamasha Tailam, Rasnadashmulagradam, Kulutagradam are found to be effective. And externally, Ubanaham with the Jivani Udortana Churnam, Varaha Vasa Lepa or Mahisha Vasa will also help. Ashavanna, Mahakuda Mamsa Taila, Shashtika Taila externally is found to be effective. Then compressive neuropathy, diabetes mellitus patients are more prone for compressive neuropathies for superficial peripheral nerves. Most common is ulnar nerve in the upper limb leading to claw hand and peroneal in the lower limb leading to foot drop. So this is one of our patients with ulnar neuropathy came to OP in the morning session, but we started treatment by about within 20 hours. Next day he became all right. I'll show the video, photos. It's the wrist droop, claw hand, foot drop. So what is the management principle here? Always rule out Hansen's disease, then advise good postures, advise cushion usage, change position frequently, and Murivanna Kaitramini Thalan can be given externally, and local Lebana, we can go for the combination. This combination is very effective. It consists of egg white, gokshidam, sallaki, powder sallaki, and mankud. That we'll explain later. So cranial mononeuropathies, the most common cranial neuropathy is 7th nerve actually, but rarely 3rd, 4th, and 6th nerve are also found to be effective. Axonopathy is the root cause. If early managed, full recovery within 3 to 5 months. Generally, 7th cranial nerve palsy and all will need up to 3 months. So this is one example for that. Bell's palsy-like presentation. Bhadradarvadi Kashayam, Rasanavadi Kashayam, Pranavadi Kashayam initially as a Shofa drug, because Shofa or pressure palsy is the most important pathology there. Then coming to the disease management, Dhananayana Kashayam, Ardhidam Akshepa Vadan, because if that condition of hemifacial palsy is not managed properly in the very initial phase with Dhananayana Kashayam, etc., in later phases we used to see presentation of hemifacial spasm, various type of hemifacial spasm in patient with the history of element facial palsy. So we also go for Dhananayana Kashayam, Ardhidam Akshepa Vadan, Maharasna Kashayam, Vidarya Kashayam, Egangavirasam, Samir Panagarasam is found to be effective. Vetimaran tab initially for controlling the inflammation, and Shilajadu Rasayana. Then externally, Karpasadi Kachiratalam, Venatalam, Kshiradumam, Nasyam, Abhingam, locally only. Ubanaham, in case of repeated hemifacial palsy, we can go for Ubanaham, Karnapurana. So points to notice, these are all take-home messages. Hyperglycemia increases endoneurial vascular resistance and reduces neuronal blood flow. So Udvartanam, Dhanyamuladhara works well here. Hyperglycemia stimulates vascular endothelial growth factor production, which induces neovascularization. So what we have to use is Tinospora cordifolia, Ocimum sanctum, Acer directa indica, Withania somnifera, Curcuma longa, Commiphora mugel, Piper nigrum, Andrographis paniculate, and Boswellia serratis having so much role in this situation. So hyperglycemia leads to auto-oxidation of glucose, generate toxic reactive oxygen, oxidative stress, and neuropathy. This is the nutshell of the pathology. So Rasaayanas, especially Shilajatu, Nisha, Amalagi, etc. Very beneficial role here. Immune modulation have a pivot role in preventing neuropathies. Rasayana is the final answer for that. So concluding, I dedicate this session to my patients who probably give a meaning to my daily existence. Thank you, Anand.
Thank you very much, Dr. Jomon. Thank you very much. We can never ever thank you enough. And I'm very sure when it comes to your classes, more the merrier. This is what we believe in. I would quickly hand over the most relevant aspect of today's conclusion. Dr. Muraleedharan sir is ready to take it to the next level. I request sir to come across and to make the concluding remarks. And I think that will make a meaningful conclusion to the entire proceedings till this lunchtime. Sir, we are all yours. Please make it complete full circle.
Thank you, Dr. Sreejit. First of all, I have to congratulate you for a beautiful moderation of this session. Your richness in vocabulary, style, and presentation really deserve congratulations and appreciation. On behalf of all assembled over here, I do that sincerely. Appreciations and congratulations, Dr. Sreejit. And since we are running a bit running behind the schedule, I would like to be brief as far as possible. For me, it was a learning experience. Each and every word of the speakers were giving me a lot of insights to the subject. Personally, I am much benefited from this. And I feel we have done justice to this particular occasion. Why? Because this is a centenary year of a renowned, very vibrant Ayurvedic institution. And we could also be vibrant by dedicating this session to the centennial celebration. I wholeheartedly congratulate the institution and the program conductor over here. And I don't want to go by one. As a whole, my impression is this. To start with, Dr. Sreeja, she has been very specific in her findings, observations, and recommendations. She said that there's a need of standard protocol for treatment, and also we lack an apex body to decide all these things. That is a very important information. And also, more important, another thing is she was doing some self-criticism. That's a great thing one can do. Iatrogenic complications, that's an important point. While referring to the Tarpana treatment for the certain eye diseases, she was criticizing the Ayurvedic community, including her, that this may perhaps be a iatrogenic complication, and that has to be avoided by taking good lessons, training, and getting lessons from the experienced people. That will save the not the doctor, but the system. And again, her specific recommendation was about Vikalpa Samprapti. That is very important because that will help to deepen our knowledge. And now we have got only general information. Most of the time we are going by general guidelines. The specificity is often lost. From generality, we have to return to specificities. That will be a gain that will be much needed for the Shastra to take it forward. And about the Dr. Vishal, I need not make any comments. Actually, he was telling about a hybrid system for the benefit of the patients. And he's mentioned about preventive eye care clinic. That's a good suggestion which can be implemented without much effort. We are all doing it, but it's often confined to the use of Tribala or some such drugs. it should not be limited to that. We should have a little more preventive ophthalmology. We may say the preventive ophthalmology has enough scope in modern times. That has to be considered. And he said that will be a natural step for the future. Yes, I take that that particular recommendation because we have to do something for the future instead of just doing something here and there. We have to shape it up and take it forward. That should be our motto, more especially when we speak on the platform of Sitaram centennial celebrations. And Dr. Gopi Krishnan, he was introduced as born to lead. I would like to say he is born to lead and win, and that is what he has explained, what he has demonstrated in his presentation. And actually, it's a very, very, very complicated area. Talking about Rasaoushadhis, that too in diabetic cases, diabetic nephropathy, it's a very hard thing to talk about. But he has done it so beautifully. I really appreciate it, and it should be a lesson to all of us because we are all facing these sort of problems every day. Why you are giving Rasaoushadhi? What is the use of it? A lot of criticism we are getting every day. But this sort of demonstration will definitely help us to have better. We will be able to give better explanation for our treatment. And one point is about the inclusion of Rasaayanas in the management of these renal diseases. IQ of the cells, that is very, very important. IQ of the cells, each cell has IQ. So we should give some medicine, Rasayana, and according to our theory, it will have some impact on the management of the disease. And he was talking about so many new medicines like Basmavasti, Dashamula Niruhavasti, and all that. Incidentally, I would like to just mention here about our experience in this particular occasion, this particular case. Dhanyamla Dhara, Dhanyamla Segam, all over the body helps to reduce the creatinine and urea level. It was tried under the guidance of late Dr. Rajagopalan sir. I'm just incidentally mentioning about it. And also, he was very particular about giving Mahadiktam preparation, Mahadiktam Kwatham preparations in renal diseases, because he says, Raktavaha Srodo Drushti, in Raktavaha Srodo Drushti, that is the best medicine of choice. That's the best medicine for a general practitioner. I'm just incidentally mentioning it here. And when we talk about, he was explaining about the diet and all that. Very often this happens when I was treating a diabetic patient. I told him to restrict from this so-called normal pathya, like this sugar and such things. A conventional pathya, but after some time he developed hematuria. And hematuria, when I discussed with him very closely, he told me he is taking pickles every day in large quantities. I asked him, why you are taking this much? You have told me just to take off sugar things from my diet, but I should have something tasty, palatable. I have started taking pickles. I like it, but I could understand. It was an omission on my part to tell him to avoid these sort of Trishnoshna things also. I used to share this experience with my colleagues, because we should not miss that point. If you are suggesting to take out certain things, to observe some restrictions in diet, at the same time, we should not leave the other part to the patient. He may make his own choices. That's from practical point of view. Anyway, the presentation was absolutely good, and it improved our insights about it. And the thing is, when I heard all these things, I am remembered of a proverb: the more you think, the more you get confused. But here, the more you think, you don't get more confused. You things become very clear and clear. So that is a lesson I have learned from the presentations. When it comes to Mr. Jomon Joseph, I have nothing to add to that. It was such a very comprehensive presentation. It was really, I thought Ayurvedic physicians have been lifted to a different level, and we should have neurology department, we should have nephrology department, and the Kaya Bala Grahurdvanga, we should have subdivisions. Then only we will be able to show our mettle to the medical fraternity. And about neuropathy also, he was talking about neuropathy may develop during even pre-diabetic state. That's a good statement, because in our Pragruba itself, it's written Karabada Daham and all that. But we take it as a Pragruba only. But actually, during that period itself, we should have an idea of instituting appropriate treatment so that the complications can be avoided. I think it is getting late, and I don't want to go to the details, too much of details of the presentation. Yeah, I hope it will be available for us for future reference. And with these words, I conclude my remarks. And again, once more, congratulating and thanking Sitaram team and praying for their bright future. Thank you. Thank you all.
Thank you, sir. Thank you very much. So you have made it a meaningful conclusion. The good thing is that we are very happy. 6,416 doctors got into our webinar. And that's always a victory in a larger scale, not just because of the numbers, but also the impact it can make. Because ultimately, more than a webinar of 2 days, what Sitaram intends is to have I would quote the exact words from Dr. Vignesh Devraj, son of Dr. Avanan sir. He was telling me a couple of nights ago, doctor, we really need to empower our Vaidya community, the doctors community. We need to enhance the quality of clinical practice. We have so much of clinical wisdom around us, but let us get in one place as much, and upliftment of the Vaidya community is very, very important. So we'll be rejoining at 2 o'clock, but Dr. Vignesh, please come over. So today, I think the number of doctors who participated exceeded 7,000, but we'll get back to exact figures later. Thank you all for the great support you had for us. And we hope the same happens next Sunday, Aachaara Rasaayanam webinar again.
Thank you, Dr. Sreejit, and thank you, Dr. Muraleedharan sir, for chairing this session. Today, we see that so many patients with so many sufferings, which we know that Ayurveda has the real potential to save them. On the other hand, we see a lot of Ayurvedic doctors, but at the same time, they need to have more exposure and more confidence to do that. So these events are like, Deepana Pajana for enhancing the Ayurvedic doctor's ability to treat. So that on one hand, we have enough patients, on one hand, we have a lot of doctors, but that Agni Mandhyam, we have to break it. And that is what we are intending with these sessions. So thank you, Dr. Sreejit. As what I wanted to tell about Dr. Sreejit, Dr. Muraleedharan sir already mentioned. And thank you, Dr. Muraleedharan sir, for concising the whole event today. And thank you, Dr. Jomon Joseph Daniel, for eye-opening many areas where the scope of Ayurveda that we have to really immerse into it. And thank you, Dr. Sreeja madam. Thank you, Dr. Vishal. And thank you, Dr. Gopi Krishna sir. All of you, we will need you again in our web platform in the coming Sundays so that we can enhance the confidence of Ayurveda doctors. When Ayurveda doctors are busy, it's a sign that the society is healthy. Sometimes people ask me, as an Ayurvedic doctor myself, when I go travel abroad, so what's the difference between Ayurveda and allopathic medicine? I say allopathic medicine is the answer to humanity's question. How can I add more years to my life? And Ayurveda is the answer to humanity's question. How can I add more life to my years? And that is what we are trying to do with this. So thank you all. Our centennial celebration is starting at 2 o'clock. Please do join, and it's really an honor for us to all of you to be a part of this centennial celebration. Thank you.